So, good morning, everyone. First of all, I'd like to sincerely thank you for making the effort to be here, despite it being a little bit more of an English weather. I was expecting a sunshine, but it's fine. And I would like also to thank Imdad for the invitation and for bringing me here. So we have a very interesting program today, this morning. It will last us a few hours. We are going to talk about the GentleMax Pro Plus. Then we're going to talk about the Picoway, which is one of my favorite devices. We're going to share some clinical pearls, some tips. We'll also talk about the wavelengths and how to incorporate them into the practice. And then we'll finish off with the Frax Pro, which is a dual wavelength. There's going to be some demonstrations, some live treatments on patients. We already have a few volunteers and a few models. But I'm here for you, really. I want all of you to walk away today with at least a couple of clinical pearls. 2 things that you can just remember from this event today that might change your practice and change the way you treat patients with lasers. If you achieve that, I'll be very content. We will have time for questions and answers, so please fire some questions, because as I said, I'm here for you, and I want all of you to enjoy this. Right, so with that, we'll start first with the GentleMax Pro Plus. That's the agenda for today, which you already have. So the GentleMax Pro Plus, which is this device here, sometimes it's a little difficult to just talk about the device without really talking about the wavelength and the technology. But I genuinely do think that this device deserves a lot of attention. So why is the GentleMax Pro Plus the number one laser hair removal platform in the world? You will see that. But when I say laser hair removal, we are going to talk about laser hair removal predominantly this morning, just because of the interest of time. But this device does much more because it has 2 wavelengths, the Alexandrite 755 and the 1064. So I'm not going to talk about the non-laser hair removal things that it can do, but if you have any questions, of course, feel free to come and ask me. But I think it's still important that we talk about laser hair removal, because many dermatologists will think, well, technology has advanced, and let's talk about fractional lasers, let's talk about pico. That is correct. But I have spoken in 83 countries around the world, and the one thing I consistently see is that particularly large, successful aesthetic clinics, large chains of clinics, always will have to rely on laser hair removal as a service. If you look worldwide as the #1 laser treatment, it's never fractional laser, it's never vascular laser, it is always laser hair removal. So laser hair removal is one of the bread and butter. It's there, going to stay, and it will always stay. So with that, what you need is a solid, reliable system for laser hair removal that has high safety and efficacy with low risk of complications. And this imagery is one of my favorite, because what it shows progress, it shows commitment to science, and it shows that from the inception, so Candela obviously has a long history with devices, and history is important too, because we all have had companies who come and say, well, we have designed this device and it all sounds promising, and in 2 years' time, the company disappears, the device has disappeared too. So it's important that you also have a company with a history, that they know what they're doing. And really what this image shows is that they have listened to the consumer. The consumer who says, give me more power, give me a shorter pulse duration to try and treat the finer hairs, give me better cooling system, give me a larger spot size, give me a faster repetition rate. This is exactly what Candela has done. So what you see is a timeline of evolution of a system. So when you stand in front of the device, the GentleMax Pro Plus, you think, okay, well, the design looks good, but this is the final product of many years of innovation and progress and advancements in this particular field. So what makes the GentleMax Pro Plus special? Well, first of all, it has 2 wavelengths, so that gives us more advantages compared to a single wavelength. It has the 755 nanometer Alexandrite. It is an Alexandrite crystal. In addition to that, it has an Nd:YAG, which again is an Nd:YAG crystal. It has multiple pulse durations, from very, very short pulse durations. When it comes to laser hair removal, the shortest pulse duration is 2 milliseconds, which means that as you progress with the treatments and the hairs become very fine, particularly on the face, then you are able to shift to a very short pulse duration, particularly in the lighter skin types. But it also means that for some of the larger targets, so if you talk about the Nd:YAG in terms of the vascular treatments, you are able to treat some of the large vascular conditions because you also have a long pulse duration. You have multiple spot sizes, so from the very, very small spot size in the Nd:YAG, for example, for the face, for facial vessels, to the 26 millimeter spot for hair removal, multiple fluences, of course, because of the power, and then DCD, dynamic cooling device, so it has a cryogen spray that selectively cools the surface of the skin. Of course, you can switch that off and just rely on cold air, but you have then the option of having the DCD or the cold air. So what are the key points to successful outcome when we talk about laser hair removal? If we talk about laser hair removal, first of all, the wavelength. The choice of the wavelength is very important. Never underestimate the choice of the wavelength for the target that you're treating, because ultimately that is the key principle of laser physics. You have a wavelength that is going to have to be absorbed by a target in the skin, a chromophore that is going to lead to a biological or a meaningful biological interaction. So the 755 nanometer has been shown that that is the ideal wavelength when you have lighter skin types, because it's a short wavelength, very strong absorption by melanin, but not too strong at the expense of epidermal injury, and you have good penetration. So it's good penetration, strong melanin absorption. But you also have the Nd:YAG, the 1064, when you have darker skin types. And we all have darker skin types. In every country, because population is mixing, population is getting darker, so you're not limited to maybe just skin type 4 or 5, for example, with a diode, but you also will be able to treat even the black skin with the 1064. The other thing is the spot size. So when it comes to laser hair removal, we know that we want a large spot size because we want good depth of penetration. We want a total volumetric heating of the entire follicular unit. So we want to get deep and heat the entire follicular unit. And for that depth, we need a large spot size. This is why we always say we start with a minimum of 12 millimeter spots. So most will start with a 12 or a 15 millimeter spots, but you now have a 26 millimeter spot. So we have the right wavelength for hair removal. We also have the right spot sizes when it comes to coverage and depth of penetration. But even if you have a large spot size, what you need is you need to have sufficient fluence to get the thermal damage to the follicular units. And there are very nice studies early in the days, in the 90s, when laser hair removal came along. Laser hair removal started in 1996. Very nice studies that showed, with biopsies, that if you use very low fluence, nothing happens. The follicular unit is still entirely intact, and there is a threshold of fluence where you start to see follicular damage, coagulation, rupture, and vaporization of the hair follicles. So you need to have a critical fluence to get that thermal damage. And this is why it's important that you have enough power in a machine, that if you have a large spot size, that you are still able to generate enough fluence to get that biological interaction. And then, of course, cooling is very important because cooling is there to protect the epidermis. So when we're generating enough heat, what we want is we want to protect the epidermis, because with laser hair removal, the target is melanin. So there's always going to be absorption by the epidermis because that's where the melanin sits. So if we cool the skin, if we cool the epidermis, then we have less risk of epidermal injury. This is why the DCD, the dynamic cooling device, is very reliable. And of course, speed. You want, especially if you have a very busy clinic and you have many patients, you want a device that's going to deliver the treatments fast so you can see more patients. And all of these can be achieved with a GentleMax Pro Plus because we have the ideal wavelengths, we have large spot size with enough power to give us good fluence and very adequate cooling. So when we talk about a GentleMax Pro Plus, many will think, okay, we have two wavelengths, 755 and 1064. That is correct, but I just want to remind you, even though in the interest of time, we're not going to spend a lot of time, I can speak for hours on these two. Just wanted to remind you that the 755 is not just for laser hair removal. It is brilliant for laser hair removal, particularly in the lighter skin types, so skin type 3, sometimes the very light skin type 4. But you can also use it for superficial benign epidermal pigmented lesions and for some of the resistant vascular lesions. And if you're interested in that, come and speak to me in the break. When it comes to the Nd:YAG has a wavelength. The 1064 is the only wavelength that is absorbed by all 3 main chromophores in the skin. So it's absorbed by hemoglobin. This is why we can use it for vascular. It's absorbed by melanin. This is why we use it for hair removal in the higher skin types. But it's also absorbed by tissue water. This is why we can use it to heat the dermis. So we can start doing treatments such as rejuvenation, diffuse redness, rosacea in the higher skin types. So this is how we would treat rosacea in a skin type 5. We will use the Nd:YAG or even acne. So really the purpose of this slide is the GentleMax Pro Plus is not just a laser hair removal platform. It's a brilliant laser hair removal platform, but if you know how to use these wavelengths, you can do much more. So this is just an image of the screen. This is just to show you that is, so we have now here the Alex, which is the 755. If you want to switch over to the Nd:YAG, all you need to do is just press this button. Here you can see which spot size is there. And what I really like about this device is per given spot size, it gives you the range of the fluence. So for example, if you're on a 15 millimeter spot, it will give you the range of the fluence, which is maximum 30 joule. So, and typically I would say if you're around 60 to 65% of that fluence for that spot size, you have a meaningful biological interaction. So you don't necessarily have to always guess in terms of the fluence, but you know that if you're using this spot size and you're choosing a fluence here, you know that it's a very high fluence. On the other hand, if you're choosing a fluence that is there, you know it's a very low fluence. So this is also something, particularly for the beginners, it's a nice guidance to know, well, look, you need to hover around 60 to 65% of the fluence in terms of the first few treatments. Here you can see the pulse durations. Now on the smaller spot sizes, look, you can go to a very short pulse duration. So with experience, you can treat some of the very tricky benign pigmented lesion even with the alexandrite because you have a very short pulse duration. This is the repetition rates, which is the hertz. This is the cooling, which is the dynamic cooling device. So this means 30 milliseconds of spraying, so enough time to spray to cool the epidermis, and then this is the delay. Now obviously if you're using very high fluences and you want to cool more, you just increase the spraying cooling. If you're dealing, for example, with a benign epidermal lesion, you can then switch off the cooling. So you're able to dial in, dial up, or dial down the amount of cooling that you can have. This is the same with the Nd:YAG, same principle, but what I wanted to draw your attention to is that with the Nd:YAG of the GentleMax Pro Plus, you're able to have a microsecond pulse. So a microsecond pulse is a pulse that is shorter than 1 millisecond. We also call it a sub-millisecond pulse, a microsecond pulse. And that is particularly good for rejuvenation, heating, generating heat in the dermis. So rosacea, acne, dilated pores, oily skin, rejuvenation, and you can combine this with many other treatments. So sometimes colleagues will come and say, oh, there is aerolase. Have you heard of aerolase? Yes, but why would anyone get excited about aerolase? Aerolase is nothing other than microsecond pulse. 650 microseconds on an Nd:YAG, a large spot size. Well, you have it here. You can go on a 250, you can go on a 500, you can go on a 750 microsecond. So don't always be drawn into the marketing. The key physics, the principles of physics remain the same. We have the ability to generate a microsecond pulse here. So this is just how it all started. The first laser hair removal wavelength was in 1996. That was a Ruby 694. Brilliant. Those skin type 2 patients who had laser hair removal with a Ruby are very, very satisfied. The problem with that is because it's a shorter wavelength, a relatively short wavelength, so it's not going to penetrate very deep, very strong melanin absorption. So all the skin type 3s, many of them developed epidermal injury, blistering, crusting, hypopigmentation. So that's not a very suitable wavelength for hair removal. This is why it was shifted in the late 90s by Candela. Candela was the first company to come up with the 755 alexandrite. And the alexandrite is the perfect wavelength for hair removal in the lighter skin types. When I say lighter skin types, that applies also to many of the Arabs who are skin type 3 or a light skin type 4, because in comparison to the ruby, it has better depth of penetration, less strong melanin absorption compared to the ruby, and therefore safer on the epidermis. So you can also safely treat the skin type 3 with the alexandrite compared to the ruby. As you get into the longer wavelength, you do have the advantage of depth of penetration, but then you lose the advantage of strong melanin absorption. In other words, if you are a skin type 2, you can still have laser hair removal with an Nd:YAG, of course, because there is still melanin absorption. But you're always going to get better results when you're treated with the 755 alexandrite, because you have the advantage of the stronger melanin absorption due to the shorter wavelength. The only reason we treat skin types 5 and 6 with the Nd:YAG is not because the Nd:YAG is better, but it's safer in those very dark skin because of the less strong melanin absorption. So these are all the spot sizes that you have now with the GentleMax Pro Plus. So you can see we have the very small spot sizes. For example, if we're dealing with the vascular, and it's very important, many are scared using the Nd:YAG on the face, and you should be scared if you're using a large spot size. But here you can have a very small spot size, so you minimize the injury. Particularly for the leg vessels and the leg veins, we have the 3 by 10 millimeter spot, a linear elliptical spot size, so that is very good. And then, of course, we have the larger spot sizes, particularly for hair removal. We also have a unique spot size for onychomycosis, which is the 5 millimeter. That is a specific spot size for onychomycosis. So we know that larger spot sizes give us better depth of penetration, okay? This is why it's always going to be better, particularly if you're treating a large area, when it comes to laser hair removal, is to use a large spot size so you get a good volumetric heating deep into the skin so you can reach the hair follicles, because we know that smaller spot sizes concentrate the energy more superficial. And you can see that here. If you have this is a small spot size, and most of the energy is here. So pretty much the hair bulb and the bulge where the stem cell is pretty much untouched. You may get some vaporization of the hair shaft, but you're not going to get long-term hair reduction because you haven't really damaged the follicular unit. Whereas you can see here, when you're using a large spot size, because of the depth of volumetric heating, the entire follicular unit is now heated, and this is how you can get successful long-term hair reduction. So spot size does matter. So why is the GentleMax Pro Plus a very successful one when it comes to hair removal? Well, it has high power. It does. And high power is important because with high power, you can get a large spot size and still drive enough fluence with a large spot size. There is no point in having a large spot size if your machine cannot deliver enough energy for that large spot size. So to have a large spot size, you need to have enough power to give you enough energy for the large spot size, okay? And then, because of the high energy, they're also able to deliver a very short pulse duration. So then you have the advantage of good depth of penetration with a large spot size, good thermal damage because of the fluence that you can generate, but also a short pulse duration, and you can also go fast. Now, the other thing to mention, just remember what I mentioned earlier, Candela were the first to come up with the alexandrite. The alexandrite crystal, and that's also important. The crystal source of alexandrite is bomb-proof, it's military grade, so this is why you can have thousands and thousands and thousands of pulses doing laser hair removal every day, and it's still very good, still very reliable, and less chance of damage. And that is because the crystal is very strong and stable. So not every alexandrite is going to behave the same. Not every Nd:YAG is going to behave the same because the quality of the crystal is not the same. So I just want you to remember, it's not always just about the wavelength. There are other things that come into factor, such as the pulse duration, the power, the fluence, but more importantly, the quality of the crystal. And the quality of the crystal of the alexandrite of Candela is the best. Right, so those of you who have used the alexandrite when it comes to hair removal will understand that most of the time you're going to be using a 3 millisecond pulse duration, okay? And it is logical, because if you really look at the hair diameter and you do the calculation for most of the hairs, you know, you don't need a very long pulse duration. And also many studies that were done initially by Candela has shown that actually you get same results with a shorter pulse duration compared to the longer pulse duration. And the advantage of the shorter pulse duration is you can also use lower fluence compared to the longer pulse duration. This is the dynamic cooling device. So the cryogen sprays and cools the surface of the skin, so the epidermis is protected, then the laser light can come, and then there is less risk of epidermal injury. Because this is what happens when you don't have cooling. When you don't have cooling, you have epidermal injury. Cooling is there to protect the epidermis. So if there is a compromise in the epidermis, the first thing you're going to have to think is, was the cooling adequate? Maybe you have undercooled because you've used high energy. So it's logic that if the fluence is high, you're also going to have to adjust the cooling and increase the cooling, okay? Maybe in a skin type 1, where there is very little melanin and very little fluence used compared to the higher skin type, you also need to reduce the cooling because you can sometimes overcool in the very lighter skin types. This is one of the early studies, a very nice study that really looked at the pulse durations in successful long-term hair reduction. And they compared the longer pulse duration, the 20 millisecond, to the shorter pulse duration, the 10 and 5. And basically what they find is that with the 5 millisecond, there was still good, on biopsies, good complete follicular thermal damage, vaporization of the hair shaft, coagulation of the follicular unit, and destruction, thermal destruction of the follicle. So this is why with the Candela devices, particularly with the alexandrites, we know that the short pulse duration works more effective, particularly after a few sessions when you're dealing with the finer hairs. Okay, another one, again, looking at the different pulse durations. And this is the alexandrite crystal. Once again, it's a military-grade, bomb-proof alexandrite crystal, very stable. You can hit it with many, many thousands of shots, and you don't get the scratches and the damage, because once you get scratches and damage into the crystal, you're not going to get a pure 755 wavelength. What we do know is definitely the shorter pulse durations work better. So some will say, well, what about a diode? Oh, okay, cheap, okay. Might be okay for the first 2-3 sessions because you have a thick hair, so you can get away with a longer pulse duration. But as you progress with the treatments and the hairs become finer, that's where the key difference is, shifting to a short pulse duration, but it's not just a short pulse duration. Remember, the 755 is also a shorter wavelength compared to the diode, so it has stronger melanin absorption, and that is why you have the advantage of better hair reduction when you start to have finer hairs. Because even in the darker skin types, finer hairs will contain less melanin compared to the thicker hairs. So when you have, even if you have a skin type 3 and you have a fine hair, what you have is, you have very low chromophore. So with low chromophore, you have to do two things. You have to shorten the wavelength, but also shorten the pulse duration. And that's where the advantage comes of the alexandrite compared to, for example, the diode. This is the clinical endpoint that you often see. You can see this edema. So you see the erythema and perifollicular edema around the hair follicle. So you see that, and that is normal. That is a clinical endpoint. This edema is obviously because of the heat that is generated around the hair follicle. So some before and afters of hairs. So we're dealing with unwanted hairs. Even for facial hirsutism, you can see these terminal hairs and facial hirsutism, and it works very well. It's a number of treatment sessions. It's not a single session. It's a number of treatment sessions. And what you want to see is you want to see a reduction in the thickness of the hair, in the hair cycle, and in the density of the hair. So the density reduces, the thickness reduces, and the hair growth cycle reduces too. So for example, if a woman is shaving, one of the questions will be, okay, how often are you shaving? If they say, well, I have to shave every 2 days, what you would expect as a successful marker of treatment after, let's say, 2 or 3 treatments, she will say, I now need to shave once every 4 days. So that is a good outcome. So instead of shaving every day or every 2 days, they're shaving every 4 days or maybe once a week. So the frequency of the hair cycle is reducing, and then they may say, I'm seeing fewer hairs and the hairs are becoming finer. And that's also when you start with skill, switching to the shorter pulse duration. So you can see also here. Right, what I also wanted to mention is that, particularly for the dermatologist amongst you, I believe most of you are dermatologists anyway, for the dermatologist particularly, this is also interesting, is that whilst in most cases, laser hair removal is done for unwanted hair, in other words, cosmetic, unwanted hair, there are also some uses from the medical point of view when you have hair follicle disorders. If you think about it, if you have a hair follicle disorder, if you're targeting the hair follicle, okay, that can also have a positive contribution to the outcome of the treatment. It doesn't have to be the sole treatment, but it can be an adjunctive and a combination treatment. So this is one of the articles that looks at the medical uses, let's say, of laser hair removal. And these are some of the conditions that you can, as a dermatologist, you could think of laser hair removal as a treatment. So for example, pilonidal sinus. Now this is not necessarily something that the dermatologists see, but now even the surgeons know that post-surgery for pilonidal sinus, and certainly for the small pilonidal sinus, laser hair removal has an adjunctive role. That if you treat with laser hair removal, you require less surgery and less risk of recurrence. So we have some surgeons who refer cases to us, and this is something to just think laterally about it. If you're dealing with, if you have collaboration with colorectal surgeons or surgeons, just think of, some of the conditions such as pilonidal sinus. Keratosis pilaris, it doesn't eliminate keratosis pilaris, but it certainly also helps, because when you're treating the hair follicle, you also reduce the risk of the scaling and the roughening of the skin. And we just submitted an article with our case series for laser hair removal and keratosis pilaris. Becker's nevus obviously often has thick terminal hairs and pigmentation. So again, from the cosmetic outcome, you can use laser hair removal for Becker's nevus. And just to remind you, when we talk about skin type, we don't always mean the skin type of the face. Why? Because someone might look like a skin type 2, but in the Becker's nevus, remember, Becker's nevus is always hyperpigmented. The Becker's nevus might be a skin type 5. So for the Becker's nevus, you're going to treat it with an Nd:YAG. So the skin typing is not always what you see on the face. Sometimes a patient might be a skin type 3 on the face, but they have a lot of hyperpigmentation in the axillae. In that case, you can't treat them with the alexandrite, you have to treat them with the Nd:YAG. So if they are having, for example, laser hair removal for the face, you will treat them with the alexandrite because they are looking like a skin type 3 on the face. But in the treated area, such as, for example, the axilla, you may need to use an Nd:YAG because that can look like a skin type 5. So it is not just the skin type of the face, it's the skin type of the treated area. And this is why having the 2 wavelengths is always beneficial, because sometimes a patient might have a darker patch. Hidradenitis suppurativa, I think this is now well known and very common that you can use laser hair removal even in combination with the biologics. In Denmark, where I am also affiliated, all patients with hidradenitis suppurativa receive laser hair removal, all patients. And we have over 300 patients now in the database who are receiving laser hair removal for hidradenitis suppurativa. Pseudofolliculitis barbae, or ingrown hairs, that's again another condition that can very nicely be treated with laser hair removal. So just think laterally, and laser hair removal doesn't always mean unwanted hair. So this is one of the articles published in the Journal of European Academy of Dermatology and Venereology that looks at laser hair removal after surgery or surgery alone in pilonidal cyst. And what it shows is if you do laser hair removal after surgery, you decrease the risk of recurrence. So this is why now many of the general surgeons are referring those cases to us. Another one, and there are many articles now on laser hair removal and hidradenitis suppurativa. This is actually a systematic review, looking at all the articles unpublished. Definite role, particularly in early stages 1 and 2, and it's safe to combine with the biologics, it's safe to combine with isotretinoin or systemic antibiotics. So that could be also another adjunctive treatment that you could do. Okay, pseudofolliculitis barbae. And if you look here at this case of pseudofolliculitis barbae, watch carefully. It's not just the ingrown hairs, the terminal hairs, but the papillar, almost keloidal-like lesions have all cleared after laser hair removal. Because this is a secondary reaction to the ingrown hair. So if you eliminate the hair by successful treatments of hair removal, this will also regress. So it's the same for acne keloidalis nuchae. That's where it's well known that for these skin types, particularly skin type 6, who develop acne keloidalis nuchae, laser hair removal with the NDAG in combination with triamcinolone injections is the treatment. Right, cooling is important. Just once again, there are different types of cooling. So we have cold air, we have contact cooling. What I would like to draw your attention to is this. When you are using very short pulse durations, this is where you have the advantage of the cryogen spray. Many times we have patients from the Middle East, who come and study in England. They will say, when I was in Dubai or I was in Doha, I was fine using the 3 milliseconds on the Alexandrite. But here they treated me with a Cynosure or with another device, and it's cold air, and I'm having burns. Because remember, it's not just the wavelength, it's not just the pulse duration, but the cooling is important too. The cryogen cooling is selectively cools the entire spot size, whereas with the cold air is a little bit unreliable. It depends also on the angulation and the duration of the spraying, whereas we know that with very short pulse duration, the cryogen in particular is very important. So, once again, just some of the key markers and differences between the older model, which is the GentleMax Pro, and this newer model, which is the GentleMax Pro Plus. You could see we have a shorter pulse duration, down to 2 milliseconds. There is no point in going even shorter. You get an explosion. So 2 milliseconds is the shortest that you would go to, and you also have a larger spot size with higher fluence. Just some examples. You can see when you get these slightly finer hairs, this is when you really need the very short pulse duration of the 2 milliseconds. So, in summary, GentleMax Pro Plus, 2 wavelengths, 755, 1064. We focused on laser hair removal, just a brief focus on laser hair removal, but remember, these wavelengths can do other things. We have a large spot size, 26 millimeter, faster repetition rate of 3 hertz, and a short pulse duration of 2 milliseconds. Right.
Don't switch the mic.
The end of part 1, which is the GentleMax Pro. What we're going to do is we're going to give you the chance of asking me some questions whilst we're switching off the mic. So please, if you have any questions, fire at us. Very much. Nice. Nice meeting you. Thank you.
And we mentioned that we need to change the wavelength and change the pulse duration. What about the skin type like 4, 5, 6? Or we are treating with the 1064?
Yeah, no, sorry. So if you have a skin type 5 and 6, then you obviously only have one choice, and that is the 1064. Because shifting to the shorter wavelength is going to obviously have an increased risk. But this is more for the, let's say, skin type 3, where maybe not in Qatar, but in many countries, the diodes, for example, or even the IPLs are very popular because they are cheaper technologies. So what I'm saying, in those cases, definitely when you're stuck and you get these finer hairs, you then have to shift to the shorter wavelength, which is the Alexandrite, because the diode is a longer wavelength, and has a longer pulse duration. But when you shift to the alexandrite, you have the advantage of a shorter wavelength, stronger melanin absorption, and shorter wavelength. If you are a skin type 5 and 6, you can still try shortening the wavelength, the pulse duration of the Nd:YAG. So you can try shortening the pulse duration, depending on the skin type. So maybe a skin type 5, so you have to test patch, even with a 10 milliseconds. But a skin type 6, you're just going to have to keep it at 20 milliseconds. But sometimes, if, for example, you are treating on 30 milliseconds with a skin type 5, you can try even just a test patch on a 10 millisecond for the very fine hairs. Skin type 4, you can even try on a 5 millisecond. But you have to do test patches first. But yeah, you are limited by the wavelength in those skin types. But for the lighter skin types, you will always get better results if you then shift to the alexandrite with a short pulse duration. Okay? No, thank you. It's a good question. It's an important practical question. Any other questions? Can I just ask, who has the alexandrite? You have? And who uses it for vascular? You do. Okay. And who uses the Nd:YAG for other things other than... Yeah, okay. Yeah. So, because I saw you were nodding. Yes, absolutely. Yeah. And I think it's great also in combination with other treatments. Okay, so for example, rosacea, a higher skin type, if you treat something with a pulse dye laser, for example, you're always risking the risk of post-inflammatory hyperpigmentation, but with the Nd:YAG will be a safer option. So that's fine. I just wanted to make sure that, you know, everyone is utilizing the 755 and the 1064 beyond laser hair removal. Sure, we'll give you
Thank you so much for your... thank you so much.
No, you're very welcome. Thank you.
I'm just wondering, you said cooling is important. I'm just wondering, is there a negative side to cooling too much?
Yes, there is. Well, I mean, if you are a light skin type patient, so the scenario where you can overcool is in the setting of low skin type, relative low fluence is needed, and overcooling. So you can just cool too much. But it's more with vascular than hair removal. Because with vascular overcooling, you can really just constrict the vessels. We see that. This is why, let's talk about the 595 as an example. So if you use the Candela V-beam, which has a cryogen spray, and you can compare that to the cold air, let's say, from Cynosure, you will find that sometimes with a very light skin type, with a very, very light pinkness, patients are going to say, I'm getting better results with the V-beam. And that is, of course, because of the difference in terms of the pulse structure, that's one difference, but also because of the cooling. Because with the cold air, if you're treating the cheek and you're staying there for a few minutes, there's a lot of vasoconstriction. You lose the target. Whereas with the cryogen, you're only firing the cooling on the treated area, so there is less chance for the rest of the vessels to constrict. So overcooling can be an important part in vascular, but I think in very low chromophore, so let's say a skin type 1 or a skin type 2, when you're using, in the beginning, low fluences, you really don't need to use 40 millisecond spraying. It's just too much cooling. On another hand, in the very dark skin, sometimes a spraying of 50 milliseconds can cause PIH. So there are some patients with very dark skins that when you increase the cooling to 50 milliseconds spraying time, they may get some post-inflammatory hyperpigmentation. If that is the case, just switch to cold air in that case. Because most of the time you're going to be using the Nd:YAG anyway, so you're using longer pulse durations, so you have less risk of damage. So to summarize, in vascular, definitely. In very low chromophore, you can overcool and lose the targets. And very rarely in the very dark skins, you may see some PIH from cryogen. It has been reported. In that case, you can then switch over to cold air.
You can only know that if you're doing a patch test.
Yes.
You don't have like a tip where you're like, oh, this is too much.
No, for vascular, for sure. No, for vascular, if you're dealing with a skin type 1 and 2, you don't need a lot of cooling.
We're talking about skin type 3, maybe 4. You do cooling after.
No, I think for skin type 3 and 4, if in the context of hair removal,
Pure vascular.
for pure vascular. Skin type 3, you can also overcool. Skin type 4, you will risk if you undercool. So for skin type 3, if I'm not seeing good vessel closure, I might need to reduce just the cooling a little bit down. Yeah? Sometimes you will see a lot of whitening on the surface of the skin from the cryogen. If you see that, you're probably using too much cryogen, so you can then reduce the spraying time. When you see just the spraying for a bit too long. If you see that.
So if you see frosting,
If you see the frosting, that means you're probably overcooling in a low skin type. In a low skin type. And that frosting in a higher skin type can sometimes cause PIH. Okay? Right. So we had a question about cooling. We had a question about the finer hairs. Any other questions? Question from the back tables? No? There's a question there. We'll get the mic. More questions means more engagement. No, you're very welcome. Is the mic actually working? You're very welcome. I really can't hear you. I don't think this mic is working. Yes, I can try and hear.
It's about the melasma.
Yes.
You mentioned here alexandrite.
Yes.
And exactly in the melasma.
Yeah. Okay. So please let me make it very clear. Yeah. No. Let me make it very clear. When we talk about the alexandrites in the context of pigmentation, I'll be very clear with you. Solar lentigos, freckles, café au lait macule. Only. No melasma. No melasma. I do not treat solar lentigos, so lentigos, and freckles, lentigens, so lentiginous, solar lentigos, and maybe a café au lait macule, but to be honest, I have a Pico, and if you have a Pico, you would use that. But I'm just thinking if the only device you have is alexandrite and you don't have any other things, these are the three conditions that you can treat. I do not treat melasma with the alexandrite. Melasma is obviously a very complex condition. There's a vascular components and other components, but do not treat melasma with alexandrite because you may risk worsening it, okay? I know that some use it and they say for the epidermal melasma, you're playing with fire.
How to treat the paradoxical side effect?
Which side effect? Paradoxical hypertrichosis? Okay, well, the best way to treat paradoxical hypertrichosis, in all honesty, and I'm not being sarcastic, is to identify who's at risk and not treat them. So typically the skin type 3 with the very, very fine hairs on the side of the face, who put a lot of pressure on the doctor to treat, these patients are at high risk of developing hypertrichosis, secondary hypertrichosis. What you could do is if you can use the alexandrite. Let's say if they are a lighter skin type, use the alexandrite. You use the very short pulse duration, okay, with the high fluence. You pre-cool, so you have to use external cooling. Ice pack or cold air, you pre-cool the area. Then you do 2 passes. I know it's high risk. You do 2 passes. And you post-cool afterwards for a minimum of 5 months. And you reduce the interval treatment sessions. So you do them every 2 weeks. So you do every 2 weeks. You do 2 passes with high energy, short pulse, and pre and post cooling. So it's not for everyone, okay? But that's the only way, and this has been published, by the way, to really target those very fine hairs of paradoxical hypertrichosis. And again, not everyone will clear, okay? But it's been shown that if you persist with treatment, ultimately you will get some improvement. So you shorten the interval, you shorten the pulse duration, you increase the fluence, you do 2 passes, and you and most importantly, post-cool. But really, we see them. If they come with very fine hairs, we don't treat. Okay? Oh, there is one question. Maybe this will be the last question then before I talk about Picoway. Yeah. Thank you. Very welcome. Yes.
I have tried a few times, but I'm afraid to use
Yes. Okay. Can I ask? Okay. So just so that everyone can hear the question was with the Nd:YAG in vascular. My colleague has some reservations because of the risk of scarring. So here is my question to you. What spot size were you using? Mohammed, what spot size were you using? Because the risk increases with the larger spot size if you're talking about the telangiectasias on the face. This is why I showed earlier the GentleMax Pro Plus has the 1.5 millimeter spot. So the 1.5 millimeter spot is a very small spot size with much, much lower risk of scarring when you're using on the face. If you're using the 6 millimeter, for example, if you're using a 6 millimeter or a 5 millimeter, still, well, unless you're using it for venous malformation or a big venous lake, if you're using it for vessels, it's too high risk for developing atrophy. So really you need to use the small spot size. Which spot size? Yeah, but have you developed really a scar from 1.5? No, you don't need to be, well, I mean, you don't need to be afraid if you're using the 1.5, if you're using the right fluence and the right pulse duration. So I hear what you say. There is a risk, but the risk is significantly higher with a larger spot size. With a 1.5 millimeter, I've never seen anyone had a scar with a 1.5. All right?
That's a 1.5 on the face.
On the face.
What's your biggest on the legs? 4 millimeters?
I use the 3 by 10 millimeter. I use the 3 by 10 millimeter, so the 3 by 10 is the linear spot size. It's a linear spot size. It's 3 by 10 millimeters, so it's a linear spot size, so you can just treat individual vessels. We'll show it to you. It's a linear spot size, or the 3 millimeter.
Or the 3 millimeters?
Yeah.
Don't do the 4.
No, here you have 3 or 6. You don't have the gradation between 4 to 5, 6. So you only have 3 or 6 or 3 by 10.
Something slightly bigger than the actual vessel, or do you sometimes go with a smaller size even if the vessel is bigger than your spot?
No.
Maybe they do a 1.5 on the vessel on the leg.
I think 1.5 on the leg is probably too small because you're also limited with a bit of the depth of penetration. I always use the 3, almost always use the 3 or the 3 by 10. So even if it's a smaller vessel and using the 3, that's fine because you're getting right coagulation of the vessel. If it's a very large vessel, maybe just for the feeder vessel, I will use the 6 millimeter, just for the feeder vessel. But for the branches, for the reticular vessels and the smaller telangiectasia, I will still use the 3 or the 3 by 10. Okay? Right. I'm very passionate about the Picoway. Well, for 2 reasons. First of all, I do see a lot of cases of pigmentation and a lot of cases of things that I can use the Pico for. So that's one. And the second thing is I think we need to be honest. If we look at what has been the major advancements in laser over the 15 years, it's been 2 things, fractional laser and picosecond. The rest is just all a variation of what we know, just a newer packaging or different spot sizes. So really, picosecond lasers are an advantage, and fractional laser. So the Picoway, as you can see, which is that device there at the end, is the picosecond laser from Candela. So let's just warm you up a little bit and talk about picosecond lasers before we talk actually about the Picoway. So picosecond lasers have been around for almost 12 years now. So the first Pico laser came out in 2012. The key difference between the Pico and the Nano is in the pulse duration. And the pulse duration is important. Pulse duration is the key factor in differentiating between the different picosecond lasers. So that's important. Don't just think, okay, it's a Pico, it's the same wavelength. You need to also look at the pulse duration. Because what happens is, as you go shorter with the wavelength, you have less heat and you have more photomechanical, photoacoustic effect. So with the nanosecond, which most of you are very familiar with, the nanosecond has been around and it's very popular in the Middle East. With a nanosecond, because of the relative longer pulse duration, you can see here, you have predominantly a photothermal effect and of course some photoacoustic effect. But with the picosecond, you have predominantly a photoacoustic effect. And that is important because that means lower risk because we have less thermal risk. So particularly initially for the tattoos, definitely for tattoos is a big difference when you switch from the nano to the pico, but we also use it in many other things other than tattoos, such as pigmentation, and of course with the fractional handpieces, we can use it also for scarring. So 1 nanosecond is 1,000 picosecond. This is important. Why? Because you can have a pico that is 950 picoseconds. The company will come to you and say, we are a pico. And then you think, okay, well, they are a pico. But they are a 950 picosecond, whereas another company can have a pico that is 250 picoseconds. So you're still within this pico range, but there is a big difference between 950 to 250 picoseconds. So it's not enough to be just a pico. You need to know how short the wavelength is. These are some of my publications on pico. It's something that is of interest to me. When we learn lasers, when most of us learn lasers, the first thing we learn is something called the selective photothermalysis theory. This is one of the first things we learn. Selective photothermalysis theory in principle means smaller objects, short pulse duration, larger objects, long pulse duration. This is correct for millisecond lasers and for nanosecond lasers. But when we shift to picosecond lasers, actually it's no longer a thermal relaxation time that is important. It's a stress relaxation time. Because remember, with a very short pulse duration of the pico, we are not really generating heat. If you look at the Picoway, we are using 1 joule. 1 joule. We are not really generating heat, are we? And the patient will say, well, it's not heat, it's just a vibration. But what we have is something called a stress relaxation time. So we also need to learn another concept. So we build up on the thermal relaxation time that stops at nanosecond. When we enter the territory of the picosecond, we need to be familiar with the stress relaxation time. So the shorter the pulse duration, the more stress you generate. The shorter the pulse duration, the more stress you generate in the tissue. So that stress that you generate in the tissue can exceed the resistance force of the particle. And this is why the shorter the wavelength, the better it is in rupturing, for example, a pigment tattoo. Because the shorter the wavelength, the more stress force you have. And if you look at histology, because the histology is also going to give us a very good lesson. If you look at the histology for the same wavelength, 532, and matching, same spot size and matching fluences, and you can see the difference between the nano and the pico. The nano, the damage is not selective. There is still damage to the basement membrane. There is vacuolization, ballooning of the cells, and this is why there is risk of post-inflammatory hyperpigmentation. Anyone who's treated many patients with the nano 532 will see that there is risk of PIH because there is too much inflammation, too much damage and disruption to the basal melanocytes. Whereas if you look at the pico, because of the very short pulse duration, the injury is mostly confined within the melanocytes. There is selective melanosome damage with very little damage to the basement membrane and the rest. This is why the risk of post-inflammatory hyperpigmentation is much, much lower compared to the nano. So even though the wavelength is the same, but what happens actually in the skin and the tissue is entirely different. And this is a very powerful image to really relay that message, that it's not always the wavelength, it's not always the spot size, but the biological interaction in the tissue largely depends on the pulse duration. And this is another way of explaining it. This is going from very short pulse duration, from very long pulse duration to very short pulse duration. This is what happens when we use a microsecond. Let's say you use a millisecond or a microsecond alexandrite to treat a junctional nevus or a lentigo. Everything is heated. This is why we get crusting. This is why we get crusting, because you destroy also the keratinocytes and you destroy the basement membrane because the heat is not selective. It's too long pulse duration. So everything is heated, so everything sloughs off. Then you go into the nanosecond. You get a mixture, as you saw in the previous histology. Damage to the melanosome, but some damage outside the melanosome. And then you shift to the very short pulsation, the pico, the damages within the melanosomes. So going from a long pulsation to a very short pulsation, you shorten the collateral damage of the heat and you confine it within the melanosomes, which means higher safety and more specificity in terms of treating pigment. This is why, if you, for example, want to treat a junctional nevus, yes, sometimes it's preferable to use a longer pulsation because you want everything to be heated and everything to be removed. But when you are treating pigment within the skin, then it's better to use a very short pulsation such as the pico, okay? And then how do we work with pigment? Well, we obviously, the location of pigment is important too, whether it's superficial in the epidermis or whether it's deep in the dermis. So the shorter the wavelength, two things. The shorter the wavelength, the more superficial the penetration is, but also the more inflammatory, okay? It's a short wavelength, high energy, high impact, physics. So it's more inflammatory, okay? And then the longer the wavelength, the deeper you get. And each has a different endpoint. When you're treating epidermal pigment, you're generating a lot of gas. Okay, you're using a short pulsate, short wavelength, the 532, high energy, high tissue interaction, rapid gas formation, nitrogen gas formation, so you see the white frosting. And then, with the longer wavelength, the frosting is more gray. So here is white, here is more gray. But when you get into the 1064, you should not see frosting. Because if you see the frosting, that means there is too much epidermal injury, because the 1064 is predominantly in the dermis. So you're not going to have that gas explosion that really gives you the whitening on the surface of the skin. So it's also learning the endpoints. Here, you will see frosting. There, you will see just redness, edema, swelling, but no frosting. If we're dealing with epidermal pigment, this is what we deal with. We deal with a 532 or a 730, which is a unique wavelength for epidermal pigments in the higher skin types. But if we're dealing with a very dark skin or with dermal pigments, then we need the 1064, okay? So we have, with the Picoway, we have the 532, we have the 730, and we have the 1064. So we can cater for all skin types. We can go hard on all the epidermal for the 532, but if it's an Asian skin with epidermal pigments, we have the 730, and if you need to get into the dermis, we have the 1064. And of course, we also have the fractional handpieces, and this is also another big difference between the nano and the pico, is also the advantage of the fractional handpieces there. So this is just a recent patient I have treated. Obviously, you can see she's from Mauritius, and this was a biopsy-proven ochronosis, biopsy-proven. She had, for years, used hydroquinone, and she had about 4 treatments with the Picoway. There's a little bit still left, but definite improvement. She's very happy. This you cannot get with the 755. And this is just the power of the 1064. Why sometimes the wavelength is very important. If you treat her with a 755, too aggressive on this very dark skin type, okay, you can get hypopigmentation. So the only choice here is high energy on a 1064. Because 1064 is still going to be safe, very safe. Even in black skin is very safe, but you need then high energy. Now, how do you get the high energy? Well, first of all, you do have high power with the Picoway, but you have the advantage of a very short pulsation. So the very short pulsation of the 1064 of the Picoway means that you can treat also with high fluence the very dark skin, and you're still safe. And this is just a powerful message of showing why the Picoway 1064 will perform better than the shorter wavelengths. So these are the different handpieces that we have. So we have the Zoom handpiece, which is the 532 and 1064. We also have the 785. That came first, and then came the 730. Now the 730 is the most popular. 730, nice wavelength between 532 and 1064. Strong absorption by melanin, still relative superficial, so safe in the darker skin when we're treating epidermal pigment. In countries like Thailand, where most of the patients are more skin type 5, they actually prefer the 785, okay? Then we have the fractional handpieces that are called the Resolve. We have the 1064 resolve, which predominantly is in the dermis, so we use that, for example, for scarring, and then the 532, mostly in the epidermis, so that is brilliant for diffuse freckling, peppering of the skin. Particularly when you see a skin type 2 with lots and lots of lentigos, you just blast them with the 532 resolve fusion few passes, and then most of it will clear. So 730, by the way, the only company in the world that has the 730 wavelength is the Candela, is the Picoway. So 730 has shorter wavelength compared to the 755, so it is going to have stronger melanin absorption if we compare it to the 755, because it's still 25 nanometers shorter. But it has the highest melanosome to blood relationship. What does that mean? That means there is very strong melanin absorption by 730, very poor hemoglobin absorption. This is why we don't get the purpura. So when we treat with 532 at a certain energy level, we get purpura post-treatment. Why? Because 532 obviously is also absorbed by blood. It's absorbed by hemoglobin. But because the pulse duration is very short, we don't get coagulation, but we get rupturing of the tiny little capillaries, and this is why we get the purpura. Whereas with the 730, we have strong melanin absorption, but negligible hemoglobin absorption, so we don't get the purpura. And sometimes the purpura can cause PIH. So if we start briefly about tattoos. Now, the 532 is what we are going to use for the red, orange, yellow, purple colors. When we have green, blue colors, use the maximum energy, the tattoo is going to clear. But you're going to get atrophy, hypopigmentation, textural changes. So the take-home message is that we want to treat the tattoo as much as we can, preserving the epidermis as much possible as we can. This is why we start with larger spot sizes. So we have the depth of penetration. We need lower fluences with a larger spot size, preserving the epidermis, because with the lower fluence, there's going to be less impact on the epidermis. And then, as the chromophore decreases, we have to increase the fluence. So this is the advantage of having high power, short pulse durations, that we can start with a 6 millimeter, then go on a 5 millimeter, then on the 4, and then end up with a 3. Rather than with many of the nanos, most will say, I have to start with a 3 millimeter high energy because otherwise I don't get frosting. This is why when you look carefully at the skin, you see evidence of hypopigmentation or textural changes. So the key thing is we want less of that. I'm going to ask you another question. And this is something that's been published. There was actually recently a publication in the Journal American Academy of Dermatology. What is the commonest tattoo color in the world? Black, correct? The commonest, 70 to 75% of all the tattoos are black in color, correct? Right, so if you, and this is purely a business mindset, so if you are going to offer a tattoo removal service, okay, the key is not to market for a green tattoo or for an orange tattoo. You want to have the bread and butter. You want to be excellent at the black tattoos. So you need to have a wavelength that is very strong for black tattoos, which is the 1064. Because the 1064 will allow you to treat all the skin types, even the darker skin types, with a tan, with a black tattoo, and you have the shortest pulse duration. This is why for all the chains in the world, okay, when you look at the very large chains in the world that solely deal with tattoos, they have the Picoway. Because there's no point in having an alexandrite if you're treating Picoway, and if 7 out of 10 times you're treating black tattoos. Yes, the alexandrite might be good for green tattoos, but you just answered the question. Most of the time the tattoos are black, so you want a strong, efficient 1064 with a large spots and short pulse duration. This is why the Picoway is the #1 for tattoos. We will take questions at the end, please, okay? Right, in terms of the intervals, this is what we do. We actually like long intervals. You're blasting the tattoo. The pigment is going to have lots of tiny little particles. We rely on the macrophages to clear them. This takes time. And it's also been shown that when you use longer intervals, you reduce the risk of post-inflammatory hyperpigmentation and reduce the risk of atrophy and textural changes. So we start first with 2 months and then every 3 months. We learned a lot from COVID. Some patients disappeared for 6 months or a year, and they actually reported that as time went by, there was further lightening and lightening of the tattoo. So no rush, minimum 8 weeks interval. So some examples of tattoo. This would be the 532, that would be the 1064. This will be easier than that because there is more density of the ink here compared to there. 1064, but what you see is no textural changes, no atrophy or hypopigmentation or scarring. Often with a nano, if you look carefully, you will see sometimes evidence of hypopigmentation or scarring. Even cosmetic tattoos, you can also nicely treat them. And again, the advantage here is you can just go on a 5 or a 6 millimeter. You don't need a high fluence. 1 joule will be enough, sometimes 0.8 millimeter, and you get nice clearance. Here, of course, you will need a shield, an ocular shield, but you can also treat the eyelid line. Parameters and endpoints. Well, okay, so those of you who have experience with a Q-switch or the Pico will relate to the following. I'm going to explain it by giving you an example. Let's say you have a skin type 2 and you have a lentigo, and you choose the 532 and you choose the lowest fluence. Nothing's going to happen. You fire, nothing. You then increase slightly, then you might see a little bit of redness, okay? Then you increase a little bit and you maybe see a little bit of graying, maybe 1 dot of frost. And then you increase more and then you will see frosting. And then you increase a lot and then you'll see too much frosting and purpura. So it's a spectrum, okay? From nothing to erythema, graying, white frosting, and intense frosting. And that grade depends also on the skin type. So the whiter, the lower the skin type, the whiter the frosting can be, because they can just get erythema and it will settle. The darker the skin type, the more you tone it down and you step back. You want maybe just a little bit of graying or light frosting, but not very strong frosting. So it's a spectrum. In summary, you want, in an epidermal pigment, you want as much frosting as possible for the skin type. I repeat. You want as much frosting as possible for the skin type. So you want to see some frosting, which is likely to give us a better outcome. But you cannot have the same frosting in a skin type 5 that you see in a skin type 2, because the frosting that you get in a skin type 5 that is similar to the frosting that in skin type 2 is going to give PIH. So just remember, lighter skin types, you can be more intense. Higher skin types, the frosting will going to be a little bit subtle. Now with dermal pigments is a little bit different. What you see is erythema. So sometimes you have to wait. You just wait and you see, okay, it's getting a little bit red. Or you use dermoscopy and you see the change in the pigment. You see the erythema, darkening of the pigment. Sometimes pinpoint bleeding, especially in nevus of Ota, for example. In nevus of Ota, typically, you will see a little bit of purpura. You need high energy because it's a very solid, stable pigment. In skin types 5 and 6, edema, you will see swelling afterwards, okay? That's a very good endpoint in skin types 5 and 6. So if you look here, for example, this is very white frosting, and that is from the 532, whereas you will see from the 785 is more gray, and that is because it's a longer wavelength. So the shorter the wavelength, the whiter the frosting. So the danger is that if you are new to this wavelength and you want the same frosting as you are used to the 532, you're going to overtreat. So it's important that you know for the handpiece and the wavelength that you're dealing with, what is the right endpoint. So if you look at this patient here, so clearly Asian with superficial epidermal pigment, and you can see that is when so first nothing, then use slightly higher fluence and start to get the erythema, and that is when the beginning of the frosting is starting. So you can see. So that is what you want, or even just this in her skin type. Okay? Another one, this is a Chinese patient, and you can see, and that is the endpoint. And then clearance. That is the typical relative hypopigmentation that you get when they peel off, okay? And this will settle. So you don't necessarily need to see a lot of white frosting, but if within 1 to 2 minutes after the treatment you see this, which is darkening of the lesions with minimal erythema around them. What you don't want is you don't want the entire lentigo in a sea of erythema. That implies too much energy. So you want a little bit of pinkness around it, but you want this to darken and stand out, okay? So, algorithm to settings. First, you choose the wavelength. If you're dealing with an epidermal problem, 532. If you're dealing with an epidermal problem in a higher skin type, 730, 755, 785. If you're dealing with 1064, if you're dealing with dermal or very dark skin, then you have no choice but to use the 1064. Then you choose the spot size. For lentigos, we want to use a small spot size. Why? Well, physics. When you use a small spot size, you concentrate the fluids superficially. Small spot size, superficial. Where is the lentigo? The lentigo is in the epidermis. So there is no point in using a 7 millimeter spot and getting all the energy deep. When you want it to concentrate superficially, so small spot size, this is why everyone uses a 3 or a 4 millimeter. We get better results. So for small lentigos, for freckles, small spot size. If we're doing laser toning, 1064, toning, multiple passes, which everyone is aware of, that is with the large spot size. Large meaning minimum 5 millimeter. If you have a skin type 6, you use an 8 millimeter spots. And that is the advantage of having the Picoway, because you can go up to 10 millimeter spots. So skin type 5 and 6, 8 millimeter. Skin type 3 and 4, 6 millimeter. Skin type 2, 5 millimeter. That's how I would do toning. If you have solid, stable dermal pigment, you want two things. You want good depth of penetration, but you also want to have enough fluence to give you a biological interaction. This is why it's usually between 4 to 6 millimeter. Because you can use a 10 millimeter spot, but then you don't have enough fluence. So you have the advantage of depth, but you don't have the advantage of breaking the pigments. Again, you can use a 3 millimeter maximum fluence and everything clears, but then at the cost of epidermal injury. So it's all about a balance between safety and efficacy. And then, of course, it's the end point.
I'll start applying to the
Yeah, sure.
So I think we have 20 minutes and
Okay.
we'll give it 10 minutes break.
Sure. Thank you. Now, the whole point of me giving a lecture is to share with you how I do things, okay? So, how do I do things? Al Niaimi algorithm for epidermal pigment. So the Al Niaimi algorithm for epidermal pigment, by the way, I'm also from Arabic origin. I was born in Iraq. I classify the epidermal pigment into 3 different types of epidermal pigments. It's either well-defined, so if I give the patient a white pencil, they will be able to mark exactly where the borders are. Or it's diffuse, you really can't tell, and classic diffuse, or a mixture. Some well-defined, and then peppering. So this is the Al Niaimi approach to epidermal pigment. Is it well-defined, is it diffuse, or is it mixture? And this is my algorithm. So I'll walk you through it. Let's say it's epidermal pigment. If it's isolated lesions, so well-defined lesions, then you're going to treat them with a zoom handpiece. Low skin type, 532. Higher skin type, 730. Endpoint, frosting. So that's for the well-defined lesions. If it's diffuse pigment, so peppering, then I have 2 choices. In the lighter skin type, I will use the fractional handpiece, Resolve 532, multiple passes, carpet bomb everything. All the diffuse pigments will clear. Or in the higher skin types, I'll use toning. Okay? So, lower skin type, 532 Resolve Fusion, higher skin type, toning. If it's mixed, you always treat the lesions first with the zoom, followed by, if it's a light skin type, I will add in the 532 Resolve Fusion, or if it's high skin type, then toning. In other words, isolated lesions, you have to chase them first. Lentigos need to be chased. Just like with vascular, I always say vessels need to be chased. Vessels need to be chased, lentigos need to be chased. So where you have the well-defined lentigos, you hit them first. 532 or 730. And then, diffuse pigment, lighter skin type, you just add in the 532 Resolve Fusion. Higher skin type, you can just do toning. If I'm dealing with dermal pigments, then you have 2 types of pigments. You have the unstable unstable, dynamic, inflammatory pigments, such as melasma or post-inflammatory hyperpigmentation, you have to be very careful. So it's toning only. And maybe very light setting of Resolve 1064 for a little bit of dermal remodeling, but not aggressive. If you have solid, stable pigment, nevus of Ota, Adnum, then you use the 1064 in a focused mode, so not defocused, focused, pulsed, 3 to 6 millimeter, few passes. So this is what I meant with having the combination of depth of penetration but enough fluence. So there are two types of dermal pigments. Am I dealing with a dynamic one? So melasma, PIH, it can get worse. Last week it was worse. Last month it was better. So it's not the solid, stable pigment. So you can't put too much energy in there. You have to approach it gently. So toning and other things. But if it's solid pigment, then you just blast it. So you need the advantage of depth of penetration and energy. So I'll start with a 6 millimeter, 1.2, and then I will shift to the 5 millimeter, 1.4, 1.6, until I see the endpoints, erythema, darkening of the lesion, or pinpoint petechiae in the solid, stable pigments. So that's how I approach. Now, if you just have that in mind, I promise everything will be easy. Because then it's a matter of how do you deal with this? Well, well-defined lesion, you have to hit them first with a zoom, with a small spot size, chasing the frosting. Then you have an option of toning or the 532 Resolve Fusion. And then it becomes second nature. So, well-defined, diffuse, or mix is well-defined. So it's well-defined in a lighter skin, so you can hit it with a 532 zoom. So 3 millimeter, you can start with 0.8, 1 joule, chase the frosting, he's a light skin type, and that's it. That's all you need. This is a mixture, so you can see. So some well-defined ones, so you can hit them first. So take a 532, 3 millimeter, 0.81, hit them, get some frosting, and then she's a light skin type, perfect for the 532 Resolve Fusion, and then carpet bomb everything. She only wanted this one treated. She only wanted this one treated. So according to the classification, this would be a well-defined, it's epidermal, so it's 532 or 730. She's Chinese, so you shift to the 730, and then it goes. So again, 730, 3 millimeter, 1.4, a little bit of frosting, and then it disappears. Dark skin with a mixture, okay? A mixture of epidermal and some, you can see the background of melasma, okay? So you're gonna have to trade carefully here. So the epidermal ones, the well-defined, you're gonna have to shift to the 730 instead of the 532. You treat that. She's a darker skin type, so a little bit of fractional with the 1064, and toning because of her skin type. 532 Resolve Fusion is going to be too aggressive on her, and that's what you will get. So hit those ones with the 730, 1064 toning with 1064 fractional. Diffuse, this is diffuse. So 532 Resolve Fusion. So just literally, that's all you need. Because otherwise with the zoom, you're going to spend the whole day chasing all. No, 532 Resolve Fusion, put it on 0.4 millijoules, 6 hertz, 3 to 4 passes, and then all of it will darken and fall, and you can see she didn't want it to be too close to the eye, and you can see the difference between the non-treated and the treated area. Same here. 532 Resolve Fusion, because this is just diffuse in a low skin type. If she was a higher skin type, 1064 toning, that's all you could do. Pigment under the eye, it can only work if it's superficial epidermal pigment. Okay, just not talking about the dark circles. Again, this is mixed pattern. You have the well-defined ones, and then you have the diffuse. So the well-defined ones had to be hit first. Lentigos had to be chased. Higher skin type, shift to the 730. Lighter skin type, 532. No response to the 730, you have to shift to the 532 because it's the same principle. When you're stuck with a longer wavelength, then you have to shift to a shorter wavelength when it comes to the pigment. So 730 or 532, but if you have 730, use that, and then 532 fractional with her skin type. You could have also used just toning. And sometimes I use both. I hit them first with the 730, a little bit of 532 Resolve Fusion, and a bit of toning. But that's the advantage of having the platform with multiple hand pieces, then I can do what I like to do. Well-defined lesions, easy with the 532. Again, almost like this diffuse pattern with some of the more larger ones. So some of the more larger ones, you could just hit them with a 532 or with a 730, and then some 532 fractional. She's borderline in terms of skin type. You could also use the 1064 toning. You could just use the toning. But I know that in patients who can actually have the 532 Resolve Fusion, the results are going to be better. So if you have a lighter skin type, and I did this on a couple of patients, that I treated half face with toning and half face 532 Resolve Fusion. 532 Resolve Fusion side is going to clear better, for sure. It's more shorter wavelength, more intense on the superficial pigments. But in the higher skin types, it is risky. That's why we shift to the 1064 toning. So same here. Other examples you can see. Again, lentigos need to be chased. Then, she's mature skin, think lateral, think lateral. Mature skin, can she do with a bit of rejuvenation? Of course she can do. That's when you add in the 1064 Resolve. So the idea is not you see, oh yeah, I see melasma, I'm chasing the melasma. You see melasma, but you also see wrinkles and you see other things. So you think lateral. Pigments in a mature skin, I always add in the 1064 Resolve. They're going to like the rejuvenation effect. They like how the quality of the skin improves. If you want to go a step further, you can combine it with things like Profilo or skin boosters, and the patients are going to even be happier. So it's not always, I see pigment, I'm going to chase it. I just want you to think lateral. You see pigment, you chase it, but can I do something else to help the patients with the handpieces that I have that are zero consumables? Scar here, you can treat the pigment and the scar. Café au lait macule in a light skin type, 532. The endpoint has to be solid white frosting. And again, another Café au lait macule, white frosting. It's epidermal solid pigment, so it's the 532 that you're going to use, another Café au lait macule, another Café au lait macule. Now, this is interesting because this is another trick. This is more for the advanced. This is a little bit of a higher skin type. Mixed race. And this was a biopsy proven from a colleague, Café au lait macule. If you just treat him with very high fluence 532, you may risk some hypopigmentation. So in the solid epidermal pigments in the higher skin type, there is a trick. You use the 1064 on 4 millimeter. 4 millimeter 1064. 1.2 to 1.4 joule. You defocus at 3 to 4 hertz. You defocus until you hear a sound and you see a little bit of white frosting. Because what you're doing then, if you have the 1064 in contact with the skin, the focal point is going to be in the dermis. When you defocus, the focal point is going to shift to the epidermis. Now, in comparison to the 532, the 1064 has low melanin absorption, okay? So less inflammatory, less impact. So you don't want a high repetition rate that you're injuring the epidermis due to repetition of stress, mechanical stress. So it's 3 to 4 hertz, low fluence, 1.2, 1.4, 4 millimeter, defocus until you hear the loud noise, and you see a little bit of the frosting. Try it, you will love it. And this is how you can treat solid stable epidermal pigment in a higher skin type. Because if you just blast it with the 532, you're going to get hypopigmentation. And this is the beauty of the 1064, which you cannot do with the other wavelengths. Now, some will say, how is that different from the toning? Very different. Toning, larger spot size, 6 to 8, okay. Higher hertz, 7 to 10 hertz, and it's not too much of defocus and you're just doing that. That is toning. In this case, it's a 4 millimeter, more defocus, lower hertz, and the endpoint is a little bit more of a frosting. So it's different from toning. So this is another girl. This is a Mexican girl with solid epidermal pigments, and the only way to treat her is going to be with a 4 millimeter 1064 defocused in my technique, because if you're using the 532, she's going to get hypopigmentation. Other examples, Nevus pilis, another Nevus pilis, another lentigo, dark skin, another one. Another trick you could do is seborrheic keratosis. So seborrheic keratosis, you could use a 532, 2 or 3 millimeter, high repetition rate, low fluence, but defocus. And it becomes erbium YAG, it becomes cold ablation. When the 532 is defocused at a high repetition rate, but low fluence, it just becomes an ablative wavelength. Same with the 1064. So you can see, and the end point is going to be pinpoint bleeding, and the seborrheic keratosis is going to fall. That's the end point. No scarring. You can do the same for dermatosis papulosa nigra. Okay, seborrheic keratosis, no seborrheic keratosis. So you don't need the CO2 and all the crusting I'm using. Pigmentation in the back of the hand. One trick, get a microscope slide, a glass slide, compress on the lentigo, treat with the 532, because what's going to happen? The light is going to penetrate through the glass. You're going to get the frosting, but you're not going to get the purpura because you're compressing the blood away. So you have no PIH. If you, and this is experience, if you just treat with a 532 on the back of the hands, the patient is going to cry and say, there's a lot of purpura after 1 week. I'm too self-conscious about it. And the purpura on the back of the hands can sometimes last up to 3 weeks. So just microscope slide, compress, treat. You're going to get the frosting, no purpura, and it's a much faster recovery. This was a biopsy-proven lentigo. So in terms of the Al Niaimi classification, this is going to be solitary, well-defined lesion, so zoom. Light skin type, so it's going to be 532. Very simple. Pigment in the lip. Benign melanotic macule, very nice with a 532. You don't need a high energy. It will frost nicely and it will peel off. Junctional nevi. Again, if you treat them with a focused mode, it's not going to clear because this is solid, stable pigments and the pulse duration is too short. To treat junctional nevi, you need to treat them in a cold ablative way with the Picoway, which is essentially defocusing on the small spot size until you get pinpoint bleeding, and that's how you clear the junctional nevi. Pigmentation in the lip. So this is how I do. I will do a little bit of toning and very light gray frosting with the 532. We have many patients from Pakistan and India, and they absolutely hate discolored pigmented lips. So this is how I treat. Argyria, which is silver staining. Again, you can treat argyria from silver staining. It's basically a tattoo. Dermal pigments, this is lichen planus pigmentosa, horrible condition. You could see the scarring, alopecia. She was already on oral hydroxychloroquine, protopic, all of that. So this is solid, stable pigment, okay? She's already on the anti-inflammatories, so this is gonna be 5 to 6 millimeter Nd:YAG, pulsed mode, multiple passes, purpura as an endpoint. Okay, some clearance. Still there, but the patient's happy, and this is about all you can do. So what you need here, you can't treat this with a 755 or a 532. You need a strong 1064 with a short pulse duration. This is the other side. Drug-induced hyperpigmentation, 1064. Iron infusion, this is after a single session. She was very happy, didn't come back. Nevus of Ota. Same principle. You need dermal pigment. You need short pulse, high fluence on a 1064, multiple passes, pinpoint, particularly as an endpoint. Nevus of Ota. Another one. Another nevus of Ota. Another nevus of Ota. Another one. Abnum. Ochronosis, this was biopsy proven. You can see the pinpoint macules. So 1064 resolve, 1064. You can see the clearance. This is really what the difference is between a Picoway and all the others. And some will say, oh yeah, but I don't see these skin types. Well, I see those skin types. I see those skin types. So for me, if I don't have this 1064 handpiece, I'm going to turn away probably a third of the patients. You can see she's skin type 6, black. The only way to give her this nice clearance is with the 1064. But not any 1064. It has to be a large spot size so that you are not going to focus the energy on small areas and have hypopigmentation. 755 is not going to work. 1064 with small spot size because you don't have energy is not going to work. Has to be the large spot size 1064. And she's very happy, very, very nice brightening with no hypopigmentation. No nano can achieve this. You can see here again, look. This is what the Picoway is about. Some PIH from sclerotherapy. This was the ochronosis. Now, the fractional handpiece. So this is the 532 Resolve Fusion. So this is the relative newer handpiece. And it's a fusion of half the energy in a central beam and half of the energy as a donut ring around it. So what you have is if you just try and think about it, you have focal points with high energy, but you're having a wider zone of just gentle breakage of that superficial pigment. This is why with multiple passes, you just clear all that superficial epidermal diffuse pigment. You can see that. So what happens with the fractional handpiece, and again, this is not what you can really get with a nano, is you get LIOBs, light-induced optical breakdowns. You can see these bubbles. With a 1064, you get the cavitational effect. Okay, so a rupture in the dermis. So you get a biological wound healing that is not thermal. You can see that's the LIOB on imaging. You can see these bubbles. You can see the erythema there. These are the LIOBs. This is a nice paper showing the LIOBs. And again, you do not get that with a nano. So if you look here, for example, as a nano, you don't get the same interaction compared to the Pico, because it is the very, very short pulse duration that's causing this effect of the LIOB. So it's really a shift. And I think as a dermatologist, you can't just think, well, what is the difference between the Pico and the nano? If it's a lentigo, I can still clear with the nano. Well, as a dermatologist, I think we think broader. We have the advantage, obviously, of the shorter pulse duration, which means we could do much more. But we also have the advantage of the LIOBs that we get with the fractional handpieces, which means many of the dermatological conditions that we see, we can also incorporate that as part of our treatment. So what happens is you get cavitation effect, you get these bubble walls expansion, and that ultimately is going to get, this is why we hear that is cavitation bubbles, and then it's creating these shock waves, and this is why it's laser-induced optical breakdown, or it's also called thermionic laser-induced breakdown. Okay, this is one of the first key papers if you want to read about LIOBs and Pico and actually how it happens from the physics point of view. You should not read dermatology journals, but you should read physics journals. And this journal, this article is one of the key ones if you really want to understand the physics of what happens with LIOBs. So someone will ask, well, what is the difference between, for example, the 1064 resolved fractional handpiece and the non-ablative fractional handpiece? Well, the non-ablative fractional handpiece is using water as a chromophore. That's why there's a linear association between the fluence and the depth, of course, because the more fluence, the more absorption by the water, so you get deeper. Whereas here, we're not dealing with water as a chromophore. We're dealing with a 3D shock wave propagation. So it's just a shock wave that travels in a 3D dimension. That's why depth is less of an importance, because we are used to depth when we're using fractional, because we are always relying on the thermal effect, whereas here it's a non-thermal effect. This is a video just to show how painless the treatment is. You can see this is the 1064 resolved fractional handpiece. Relative high fluence, no anesthesia. It makes that noise. That noise is the cavitation sound. So we're getting these bubbles that lead to expansion, microscopic wounding, but it's not painful. I love this sound. I really love this sound. For me, it's therapeutic. I could do this treatment in 5 minutes. I can. But because the patient's paying a lot of money, we have to just talk about other things and talk about the aftercare and the skincare. But this is a treatment that is very fast. So a few years ago, I did a study. And we did histology. So we looked at what happens at histology level with a fractional resolved handpiece when we use low energy compared to high energy. So you can see this is the low energy, and you can see we have some bubbles, we have the LIOBs, but look at the higher energy and look at the LIOBs are much more larger. So we definitely have more of a cavitational effect when we're using high energy. You can see that. Higher fluence, larger, more cavitational effects, more LIOBs. And when we went on to do the pro-collagen staining, you could see significant increase in staining of procollagen type 3 with a higher energy. So we know that when it comes to a biochemical stimulation of collagen, when we want more of that wounding, for example, with scars, then we need to use the higher fluence. So for collagen stimulation, the response is proportionate to the fluence. It's not so much the depth, because it's a 3D shock wave. So how do we use the fractional handpieces? Well, if it's, the 532 is really for pigment, 64 is for the dermis. So we use it in acne scars, rejuvenation, low fluence in melasma just for dermal remodeling. We now know that melasma has mast cell infiltration, solar elastosis, senescent fibroblast, basement membrane damage, vascular components. We also know that if you rehabilitate the dermis, you can also improve. So it's more for the rejuvenation effects rather than the true pigment effect. This is another example why I really love the Picoway. So you can see this is an unfortunate girl with a burn scar. You can see the hypertrophic keloidal burn scar with a lot of pigmentation. And look, the pigmentation is completely cleared. Okay, improvements in scar. You can only do this with a Picoway because you need high energy on a 1064. Because with a 755, you're going to disrupt the pigments, and you need high energy. So this is the only way to clear all of this pigments, which otherwise was almost impossible to treat. This is with a high energy 1064, and to me, this is what makes a difference of the Picoway. So some mild acne scars. This is what you can just use the 1064 result for. This is another patient from Sri Lanka. Didn't want any risk of PIH, zero risk wanted. Can't treat with a fracture. You can treat with a Resolve 1064. Almost guaranteed no PIH. I've never seen it. Same here, Indian patient with acne scars. Can you treat with fractional microneedling RF? Yes, you can. You need anesthesia, a little bit more painful. You can, and remember, you have to pay for the tips. But if I have the Picoway 1064 Resolve, I can just treat that, and then I don't need to think about anesthesia, don't need to think about the tips. This is a scar, as you can see. So the video is not working, but 1064, and you can see improvement in the scar, but also reduction in the erythema. So when you're actually treating the scar, you remodel the scar. And this is what I mean with the lowest fluence that should give you. So first of all, the Resolve is a 6 by 6 millimeter spot size with 100 dots. You need to reach a threshold before the cavitation starts, okay? Same principle with the frosting. If you go very low fluence, nothing happens. Certain fluence, you start to see a tissue response. Erythema, graying, and then white frosting. So the same with the cavitation. In the lighter skin type, okay, you can see that around 1.7 millijoule, we really start to see a bit of a cavitational effect. When we go higher, there is much more of a cavitational effect. This is particularly important if you're treating melasma, because what we want is we want to just get to the LIOB threshold, but not too much, so that we are not too pro-inflammatory. So for the lighter skin type, with the melasma, 1.7 millijoule. But look what happens with the higher skin type, okay? Sometimes it shifts even more. The threshold is higher, okay? And you can see. So basically what I'm trying to say is that you need to see, you need two things. You need to hear the cavitation, and you need to see some of the dots so that you know that cavitation is happening in the tissue. So you cannot just say, well, everyone uses 1.9, I'm going to use it. 1.9 in someone may not give you cavitation, and in some others may be too strong. So you rely on two things, the sound and what you see. Now, if it's rejuvenation scars, you can go high. But with melasma, because we don't want to get into the pro-inflammatory, you want to just be gentle. But this is just really to show you that this is what I like about it, that you actually do have an endpoint that you can rely on. Okay? Right, so to wrap it up, how do you use these handpieces? The 532 Zoom, so that is the non-fractional classic 532 spot. Lentigos, Café macules, flat seborrheic keratosis, junctional nevi. 730, freckles, lentigos in slightly higher skin type. Toning with a 1064, general brightening, melasma, bit of dermal dyschromia. 1064 in a pulsed, focused mode, solid, stable dermal pigments. nevus aorta, for example. 1064 resolved fractional handpiece, skin tone, pores, scarring. 532 resolved fusion, the ill-defined diffuse epidermal pigments. So once again, this is the final slide just to remind you. This is what I always tell fellows who are training with me. Lentigos need to be chased. Okay, they look at me and smile, but I say, no, remember that. Lentigos need to be chased. Where you see lentigos, you chase them. 532 in the lighter skin type, 730 in the higher skin type. Then, for the diffuse pigments, if it's lighter skin type, you use the 532 resolve fusion, toning in the higher skin types. For the mix, you do both. For the melasma, you go gentle. For the solid, stable dermal pigments, you chase the endpoint of purpura or erythema, and you go with the relative high energy multiple passes. So, let's take some questions. I'm sure there must be some questions. There was actually a question there. But let's give you the mic and we'll get some questions, and then we have a couple of models, I believe. Maybe you need to remove the makeup a few. We have a colleague of mine here who I know for many years is also. I treated 5-6 years ago in Uzbekistan, and it cleared, and obviously now with the Doha sun, some lentigos, so I can treat you again. So maybe we can just get you prepared whilst we get some questions. Questions, please. You had a question first. Maybe we can give you the mic. I'm sorry. I didn't want to take your question during the presentation because I didn't want to disrupt the flow, because I knew we had Q&A session at the end. So apologies for that.
Hello. Thank you for the nice explanation.
You're welcome.
We are learning about the lasers and the treatment. I think we should have some information about the pigment as well, because when we treat tattoos, I've seen there is a difference in the eyebrow tattoo and the other traditional tattoos. And even with eyebrow tattoos, I have seen they are less responsive. So maybe there is something with the pigment.
Of course, there is a lot about.
We are not aware of that, and we don't have much information. The patient doesn't know.
Yeah, no, that's true. Definitely, there are lots of different types of pigment. Some of it is regulated, like in the EU. Some of it is not regulated, and some. I agree with you. Some of it is more resistant to treatment compared to the others. It depends on the type of pigments and the density and the ink. There are some cases where, of course, look, just because it's Pico doesn't mean it's magic. It's not. We're not talking about magic here, but we're being reasonable that. In 2024, when you have a tattoo, what options do we have and what is the best option? That is the way we will answer the question. So the options we have is obviously nano and Pico, and from these two, we came to conclusion that for black tattoos, we need the 1064 with the shortest pulse duration. That is the safest. Do all tattoos clear? No, because again, there are some inherent characteristics of the pigments that may make it resistant. For cosmetic tattoos, sometimes the progress might be slow. You just need to continue treating, and sometimes we see after 4 or 5, 6 sessions when they start to lighten. So don't give up after the first 2 sessions. We have seen some patients that have some resistance in the beginning, but if you keep going, it lightens. I see that you're nodding. Do you agree? You have that experience as well? Sometimes with the cosmetic tattoos, you just need to keep going. If you know that you're with the right wavelength, the right approach, it's just a matter of continue to treat. But yes, there are some pigments that is a little bit more difficult. But then we also have some other tricks, like doing 2 passes, combining it with fractional ablative, like fractional erbium or fractional CO2. So these are some other things that we can do for some of the resistant tattoos. So for the resistant tattoos, you can do 2 passes, obviously cool in between, make sure that you don't get the frosting. You can combine with fractional CO2 or fractional erbium. So you also have a little bit more of transepidermal elimination of the pigments. And you can do the combination. So you can do the fractional, followed by 2 passes of treatment. If it's a black tattoo in a lighter skin type, you can also do the second pass with the 532. Because remember, black absorbs all colors. So if it's a light skin type and you're no longer getting response with the 1064, you can still switch to a shorter wavelength. 730, but you may not have enough energy, so that's why you can shift to the 530. So these are all the other things that you have to try in these very resistant tattoos. Okay? Any other questions? No?
I think we need to re-energize.
Need to re-energize? Are you?
Yeah.
Okay.
So we're supposed to do the light treatments right away after presentation, but for the sake of having a break, we can take 10 minutes break, where we will prepare the patients to catch up with the time. Please join us with the snacks and coffee, and meanwhile you can discuss it with Dr. also. I think
Sure.
you need a break as well. You can discuss whatever questions you have with Dr. Firas. We'll be back after
10 minutes? Okay. See you.
10 minutes, so roughly, let's say 1:30, we'll start the live treatment. Okay?
Thank you. Turn a little bit to that side, please. Yeah, and then focus. What you actually have a little bit of that diffuse lentiginous. Just a little bit of that diffuse lentiginous. And then turn to the other side, please. And then again here, you just have diffuse lentiginous. Not really ones that I can circle, and the well-defined one is just a little bit of that diffuse lentiginous. So according to my classification, there's no melasma really here. According to my classification is that diffuse lentiginous, so it's going to be toning, 532 resolve fusion. We don't have the 532 resolve fusion here. We have the 532 resolve, okay, which is fine. So I'm going to do that. I'm going to do the combination of toning plus 532 resolve, because that is for the diffuse superficial lenticles. So if we can focus maybe on the screen, please. So this is the zoom handpiece. Yeah, you can see this is the zoom handpiece. So this is the zoom handpiece. So I'm choosing 6 millimeter. If you can just focus here, maybe you can see that's so 6 millimeter. Because remember, toning is always with 1064. Toning is with 1064. Large spot size, large meaning minimum 5 millimeter. Okay, so 6 millimeter is ideal for her skin type. And relative low fluence. So with a 6 millimeter, the maximum fluence is 1.4 joule. I like to start around 1 joule. So that's not really high in terms of energy. It's mostly photoacoustic. I choose 7 hertz. Some of you might be familiar with the nano, and you might just want to use 10 hertz. 10 hertz is really harsh on the machine. If you actually speak to the engineers, 10 hertz is going to affect the machine. So it's better to use 7 hertz. You still get the same results, but you're a little bit more gentle on the machine. So 7 hertz is just better for your machine compared to the 10 hertz. So once again, 1064 because we're dealing with toning. 6 millimeter is the minimum, sort of like the right spot size you can use up to skin type and including skin type 4. Between 0.8 to 1.2 joule, so I'm choosing 1. 7 hertz is the right. And you do multiple passes. How many? 3, 4? You see a little bit of the end point, a little bit of pinkness, mild erythema. That's enough. It depends also on the end point, on the chromophore. I'm also then going to follow it up with the 532 resolve. The 532 resolve is this one. Okay, so it says 532. Okay, but it's not the fusion. It's just a 532 resolve. So it's just single spots rather than the donut of half the energy in the spots, half the energy as a donut. And again, I'll do a few passes of that. This is going to give her brightening of the skin. Okay. Now, obviously this is 1064, so just don't necessarily look at the laser beam. I'm not going to aim at you. So, okay. No, we'll do this first. We'll do toning first. Okay, I can tell you one thing. And I've been to Korea, I've been to Taiwan, I've been to many countries. It really doesn't matter if you start with toning first or finish off with resolve, or you start with resolve first, finish off with toning. Many of my colleagues in Southeast Asia have done studies themselves, comparing, results are the same. There are half the doctors like to start with toning first, other half like to start with resolve first. Sometimes if the resolve handpiece is on, I start with that. If the zoom handpiece was on, I will start with that. So don't be too regimented in terms of which order comes first. The only difference is when I'm treating lentigos, I start with the zoom first, because if you do toning or resolve, sometimes you blur the edges of the lentigos, so I'd like to see them first. I hit them first, lentigos need to be chased, and then I will finish off with the toning. So that's the only difference. Otherwise, if I'm doing both, it depends on which one you want to start with first. Right, so the pedal is here, and then it's very simple. You just press ready, and it's ready. Okay, here we go. 1, 2. So you don't want it like this, because otherwise you'll scratch the skin. You don't want it like that, okay? Just here, like this. I like to do circulatory movements. I just like that, like this. Some like to do vertical, some like to do like this. Others like to do like this, like they do horizontal and vertical. Again, half the doctors do it like this, the other half do it like this, just creating what we call chaos. Just circulatory movements, disrupt as many melanosomes as possible. This is now my third pass. And I look and I see very minimal erythema. I'm going to do one extra pass because the end point is not that intense. Okay? Okay, so if we can maybe show there's a little bit of pinkness, just a little bit of pinkness. And actually some of the lentigos are slightly darkening. That's fine. That's a good endpoint. I'm going to do exactly the same on the other side. Can you hear there's a special sound that you hear, and that is actually what is the oscillation, the mechanical disruption of the melanosomes. I want to hear that.
So, if you would like to join Prof Niaimi, you can use table by table, just raise your hand if you like to come closer to the point and hand on pieces. Check table by table, please. If doctors would like to come, we have the goggles ready for them. Start from here, please. Okay?
Can you hear the noise? And you can see the end point. Shwayat erythema, little darkening of the lentigos, mild erythema, yeah. Yeah, nice end point. Okay? A little bit of darkening. Little erythema, and on the other side you can again see a little erythema and darkening, subtle darkening of the lentigos. That's the end point. Okay. Yeah. Yeah. Come. This one. Did you hear that? Very subtle. That's what I want to hear. Just a tweak. Okay, we're going to do just one more. Do the nose. And one more here. Okay? Right. I think we need to move on now because we still have more patients. Now we're going to do the resolve.
Thank you.
You're welcome. You're welcome. Thank you. Are we...
Yeah, this is the
532. 532. So once again, please, because I know one of you are going to ask me, diffuse, superficial benign pigment, slightly higher skin type, you know, so we could do both, toning and 532 resolve. Same principle, I use 7 hertz, okay? Now, energy, because of her skin type, okay, and she's already having a good endpoint, I don't need very high energy, okay? So I'm gonna go to around 0.7. I like 7 hertz, just for the machine. This is going, obviously because of the light, so we are going to give you extra protection of the eyes. Bright light, so we're just going to have some shielding. Okay, I'm going to just explain a few things that have been asked in the past. Can you do toning on 730 or toning on 532? Histology studies were done, okay? And it was shown that with the 1064, you get break of the melanosomes, but no damage to the cellular structure. When 755 and 532 were done, there was melanosome destruction, but there was cellular destruction as well and basement membrane destruction. In other words, toning is always going to be the safest with the 1064. The safest with the 1064, okay? This is why we do toning with the 1064. You get the melanosome disruption, but the studies have shown that on histology, there's no cellular destruction around it. The only case where I will do 532 zoom blasted toning is in skin type 1 with pheomelanin, red, orange melanin. That's the only time where you just can go with a 532 zoom, do multiple passes, like a toning. Okay? هنعمل حاجز ونكمل يعني استني بس. Resolve, and you can see you can probably see a little bit more of a green light. And those of you with goggles, you will see 100 dots. Can you see? You will see the little fractional dots. Yeah, these little fractional dots are superficial, and they're going to break the superficial pigments. So the resolve is what you will do vertical and horizontal passes. It's only the toning, you do circulatory movements. And then we'll go here. And you can see the dots. Yeah, this is the last one. ما تخافيش خلصنا. All done. Okay, and you can see endpoint is erythema, but not too intense. You can see erythema and darkening of the individual lenticulae. Maybe we can show it to the others. So the question is number of passes. That depends on which resolve handpiece. If it's resolve fusion, minimum 2. If it's this resolve, I would say minimum 3. Because with the resolve fusion, you have more coverage per single pass. So 2 minimum, but here minimum 3 or actually 4. But you have achieved the endpoints. Beautiful endpoints. You could see nice erythema, darkening of the lentigos. Nice erythema, darkening of the lentigos. We didn't do any spot treatments. All we did is toning and fractional resolve.
So we did toning first,
Yes?
and the second session was
532 resolve. 532 resolve. Fractional handpiece. Non-ablative fractional handpiece. Yeah? Okay, we can do the aftercare.
so this is what
This is, everyone can come and have a look at the endpoints if they want.
again
Yeah.
في ألم is there anyway
ألم بالsecond handpiece.
5-3.
532.
This 532 fractional is only with Pico. We can't treat like this with the spectra 5.
No, of course not. That's what I said in the lecture. Of course. The 532, the fractional handpiece that gives you the LIOBs are only in the Pico, not in the Nano.
So what kind of she needs to use panthenol or
You can use what you like. You can use panthenol, you can use simple aloe vera, you can use Cicaplast gel, you can use Cicalphate.
but no steroid,
Sorry?
no steroid, no typical steroid.
You can use steroid in the very dark skin for 2-3 days if you want to reduce the risk of PIH. You can. Yeah? Now they're putting fusicoat. That's fine with me. Okay? But I usually use Cicaplast gel or panthenol.
What about the antibiotic? There is no recommendation of no rule for
No.
as long as it's like a fractionate.
Yes. Yeah, this is non-ablative fractional. Non-ablative. There are no open wounds. So zero risk of infection. Okay? We have more models. Okay, shukran. Thank you. With a 6 millimeter, on only 1 joule, which is really not high, I want to see frosting. If I don't see frosting, I will increase the fluence. Okay? So let's see if we get that. Maybe we can move this a little bit. Thank you. All right, so let's go here. 1, 2, 3. Can you see, she even had a reaction. And it's a very, I don't think it's good. You already have a nice frosting. I can actually go even lower. I can go to the 0.8, which is really low fluence, which means still very safe, but I'm getting a reaction. So that's frosting, you can see. Shall we wait? Yeah, okay. So even with a 6 millimeter, I had nice frosting, but she felt it a bit. So let me see if I can even get the frosting with lower fluence, okay? So that it doesn't mean that you always have to be on a 3 or a 4 millimeter. Definitely not with the Pico. We're going to get it on the screen. Perfect. So can we zoom in here, this bit here, please? Here. Can you see that? Beautiful frosting. Yes. A little bit more, a little bit more. Yes, can you see that? Do you have the laser pointer? Mohammed is going to show you the beautiful frosting. The top one. Yeah, can you see? That is the white frosting. Can you see that? That is frosting. Okay? With 1 joule. 1 joule. Those of you who are familiar with nano switch, with the Q switch, will start with maybe a 4 millimeter, 3 joules, 4 joules, much, much higher energy, thermal, because even the pulse duration is longer. So that's why higher risk of complications. You can see with 1 joule we already had frosting. I'm actually dropping down to 0.8 to see if I can still get the frosting. The aim is to use the largest spot size possible with the lowest fluence for the safety. So now it's on 0.8, and I want to see if I can still get frosting. I'm going to try a new one here. 1, 2, 3. Can you see that? Beautiful frosting. 0.8. 0.8, 6 millimeter spot. So the first two treatments in her case are going to be 6 millimeter. Then I'm going to move to 5 millimeter, 2 treatments. So by treatment number 4, which probably 70% of the tattoo will going to be lighter, she's only on 5 millimeter. The risk of scarring, 0. Risk of hypopigmentation, negligible. Okay? That is the difference between a pico and a nano. Chased, so we're going to chase that first. We don't have the 730 handpiece here today, so we're going to hit that with a 532. Endpoint frosting, and then the entire area, we have 2 options, toning or 532. Because she's special, she's going to have both. She's going to have the toning and a little bit of 532. Okay? Right, makeup removed? Yeah. Not much here, there's only here.
Yes.
Yeah. Okay, we can cover the eyes, please. Okay, so lentigos, small spot size, because we want to concentrate the energy superficial. So 3 or 2 millimeter. So we'll go to 3 millimeter. Okay, this is 1064. All you need to do is press here. It changes to 532. So 532. Okay. And I will try to see what happens with 0.8. Low energy. I want to see a bit of frosting. If I don't see that, I go higher. Okay? Okay, remember this is 532, so you might see a bit of bright light. 1. Is it ready?
What is the contour line? Check the endpoint for a close overview.
Okay, here we go. 1, 2, 3. Beautiful. Beautiful endpoint I can see. Come and have a look at the endpoint. What you can see is nice frosting, not too white, little white grayish. That is the right frosting. I can actually even go a little bit lower, but I know she was fine the previous treatment. That is the frosting that you want with superficial lentigos. Okay? Can you see? That's the end point. Okay? Not too white. We'll continue. Lentigos need to be chased. Lentigos need to be chased, so we're going to treat all the lentigos that I can see. Lentigos need to be chased. Right, so remember, oh, here, there's another one. Okay, so that's the endpoint. If anyone wants to come and have a look at the endpoint, anyone wants to come and have a look at the endpoint, 532 epidermal lentigos, this is the endpoint. Because she has them mixed, we chase the individual lentigos, and now we're going to do toning. And the beauty of the Picoway, I don't need to change handpieces. I just need to change the wavelength. So here, 1064. Okay?
So when you're doing the toning, will you avoid these areas?
No, I'll treat everything. Why will I avoid the areas? No, treat everything. Of course, she will get additional benefits. No harm, 0 harm. So, going to the 6. So, toning, 6 millimeter, 1 joule, 7 hertz. Few passes. Lentigos need to be chased, just like vessels need to be chased. That's the end point. And now, just toning. Нет, больно.
No.
You get this for free.
Даже можно сказать приятно.
She's not here. She can't hear you.
It's not painful.
Okay. And now we're going to switch to the 532, dissolve, low fluence. This is optional. You don't need to. The most important is chasing the lentigos and doing the toning. Yeah, there. Yeah. I keep it on 7 hertz and then relative low energy. Here we go. This is, okay, can you hear that? Here, listen. Okay, it's a bit too strong. Come and have a look. Have a look at the, you see all the grid. Yes. Yeah? That's a bit too strong, so I'm going to go even lower. Yeah? Because of her skin type. And I'm using 532. That's it. And you can see endpoint, frosting, erythema, darkening of the other lesions.
What is the aims of this last sessions we did?
Break of the very light lentigos that I didn't hit, together with the toning. Together with the toning. Okay? All right, now we're going to put the after. 1 second. Yeah. Frosting, erythema. You can start to see a little bit of edema. A little bit of edema side and toning. Okay? Yeah. We can put the aftercare on. So, as long as you have an algorithm in mind, everything else is protocol. By the way, do you know who invented the term algorithm? Al-Khwarizmi, correct. Al-Khwarizmi, the Westerners called them Al-Khwarizm, and he invented algorithm, okay? So we should be proud of algorithms as Muslims. So, an algorithm, as long as you have an algorithm in mind, it works. Lentigos need to be chased. We're going for a small spot size. We chase the frosting. Then we go for the toning on the darker skin types. On the very low skin types, we can just do the 532. And the skin types in between, we can combine a little bit. Low energy, endpoint, erythema, darkening of the lentigos. Black tattoo, frosting. We start with the largest spot size, the lowest fluence. That gives us the frosting. We saw that nicely. The rest is practice and experience. Okay. My colleague was asking, what about the recurrence? Now, the recurrence has nothing to do with the pico. The recurrence has to do with the pathology that we're dealing with. So solar lentigos, well, if they don't use sunblock and they are exposing a lot to the sunlight, there is a chance of recurrence. So it's still the same advice, and maybe they will have a treatment once a year. Café au lait macule, we know about 20% may recur. 1 in 5 of café au lait macules, this is from published literature. Nevus avota, less risk, less chance. So it depends on the pathology, it's not so much the pico itself. Have we finished with the models?
Let's go to Frax.
Frax, yeah. Right, not a problem. Is it working? Okay, so maybe we can just, we'll do it manual first. Right, so we talked about the GentleMax, we talked about the Picoway, now we're going to talk about the Frax. The Frax, of course, as you know, is Frax Pro. So this is a standalone device, and it comes with 2 handpieces, the 1550 nanometer and the 1940. Very, very useful if you're a dermatologist or even doing aesthetics, but you will see that there are many dermatological conditions that we can treat with these. So, I mean, this is an introduction. We all know this. Facial rejuvenation really is what brings bread on table, shall we say, okay? Patients are coming to see us. Most of the time it's facial rejuvenation. And we have many different options. We have Botox, fillers, chemical peels, we have lasers. Now, the trouble with a lot of the ablative fractional is patients don't want downtime, higher risk of maybe infection, post-inflammatory, hyperpigmentation. So especially in the Middle East, this has become less popular, and therefore the non-ablative fractional methods, including the, for example, fractional radiofrequency microneedling, has become more popular. Right, so just to refresh your memory, or for those of you who are maybe starting, this is fractional technology. So fractional is an English term meaning to fractionate. You fractionate the beam of light. So you have all these columns of light spaced from each other. So this is uninjured, so the recovery is fast. We can dictate how deep we can go based on the fluence. It's a linear association because it's water absorption. And you will have quicker recovery because the stem cells from the uninjured skin are going to repopulate the injured skin. So that is fractional technology. To fractionate the beam of light columns, we can dictate how deep we can go, how close these columns are or not. If we remove tissue, so if it's ablative, that's going to be ablative fractional. If it's just non-ablative heating zones, it's non-ablative fractional. Now the Frax Pro is in a unique position. Why? That is because the Frax Pro has two wavelengths, and both of these wavelengths are in the non-ablative fractional mode. A little bit of physics to refresh your memory. We have three chromophores in the skin: melanin, hemoglobin, water. Melanin is absorbed the shorter the wavelength. Hemoglobin, specific peaks, 532, 577, 585, 595. Water starts to be absorbed from around 1,200 nanometer and above. So 1,200 nanometer, you no longer have melanin absorption, you no longer have hemoglobin absorption, you only have water absorption. Once you reach 2,000 nanometer, it starts to become ablative. So your window of non-ablative fractional is between 1,200 to 2,000 nanometer. That is why all the non-ablative fractional wavelengths are between 1,200 to 2,000. 1440, 1330, 1550, 1565, 1540, 1440, 1450, 1550, 1940. All of them are going to be between 1,200 to 2,000. But there is a difference. As you get closer to 2,000 nanometer, it becomes ablative. So the unique feature of the 1940 is a wavelength very close to the 2,000 nanometer. So it is very close to ablation, but it's still non-ablative. So it's microscopic ablation. Whereas the 1550 is completely non-ablative. So the good thing about the 1940 and the 1550 is that the 1550 is deep, and the 1940, because of its very strong absorption by water, is very superficial. So this is why we say 1550 is for dermal, deeper resurfacing, acne scars, rejuvenation. 1940 for epidermis and superficial dermis. What does that mean? That means if you have wrinkles, 1550. Acne scars, 1550, because the problem is in the dermis. But when you want to glow, when you want nadara, when you want to just have fresh surface of the skin, you need the 1940. So when you want both, of course, you are going to get results in the dermis as well as the epidermis. And the best way to explain that is by histology. Anytime you want to buy a laser machine from a company, the first thing you'll ask them is, show me the histology. Because there are many companies that come with claims, zero histology. Now, this is histology from Candela. The comparison histologically of 1550 and 1940. 1550, deep in the dermis. Because remember, less water absorption, so it penetrates deeper with the higher fluids. So this is dermal remodeling. Anytime the issues in the dermis, acne scars, atrophic scars, traumatic scars, rejuvenation, wrinkles, all of that is 1550. And look at 1940, surface of the skin. Epidermis, superficial papillary dermis, okay, a little bit of cracks in the epidermis, all of it is microscopic. So this is when you want surface of the skin to improve. Epidermal rejuvenation without the crusting and the oozing of, for example, the erbium YAG or the CO2. So, 1940, epidermal resurfacing, tone, texture, epidermal pigment, because the epidermal pigment clears as a bonus. The best way to explain the 1940 is it rehabilitates and regenerates, renews the epidermis. Where is all the superficial pigment in the epidermis? So when you remove that epidermis and you get a healthier epidermis, it's going to be less pigmented. This is why they get the glow. The 1550 scars, stretch marks, pores. So really, most will need both. The other unique feature, so first of all, we have two wavelengths. The other unique feature is that everything is in the handpiece. You don't need to change handpiece. But you have a scanner, and you have a narrow scanner width of 4 millimeter, and all the way up to 12 millimeter. This is not a consumable like some of the other competitors where you have to pay and have another handpiece. This is just in the handpiece. I'll show you. It's in the computer screen. You choose small, narrow scanner width or a large scanner width. So I'm going to ask you a question. What difference can you see between the 4 and the 12 millimeter in terms of the spots? What difference can you see? A difference that you think from the physics point of view is going to be relevant. Yes, I hear. There? Yes. What is the spacing? Yes, excellent. Now these dots represent columns of coagulation that you can see. So you see in the skin columns of coagulation. So with the 4 millimeter, the columns are very close to each other. So there's more heat in a small area. Higher tightening, but higher risk of maybe PIH in a darker skin type. Whereas with the 12 millimeter, the columns are further apart from each other, less risk of bulk heating. So this is much safer in the very dark skin. So there's also a way of how you can maximize the treatments. I will give you an example. If you have a very loose atrophic scar in a light skin type, it's better to use a 4 or a 6 millimeter with high density, do multiple passes. You can't heating in the atrophic scar to get good coagulation. On the other hand, if you have a skin type 6, they can still be treated, but you use a 12 millimeter on low density. So you have less risk of bulk heating. This is a unique feature that if you're a dermatologist and you're experienced, you can really use that to your advantage. The other thing is, like, if you have a linear scar, a surgical scar, you can just use the 4 millimeter. Just use the 4 millimeter, treat the individual surgical scar, and then treat the entire area with a 10 or an 8 millimeter. Talk to the patient. It's communication. You bond with the patient trusts you. So I say to them, madam, you're going to see me change the parameters as I treat. What I'm trying to do is, first I'm going to trace the individual scars, then I will be changing the parameters because I want to treat the entire area. This is very good communication, because when the patient leaves to another clinic, and they will just do the same, boom, 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 they will see the difference, okay? So that's an important aspect of patient treatment. So this is the handpiece, that's the roller, and you can see this is the scanner. The computer is doing the scanning for you. So it's scanning these coagulation zones very nicely, neatly close to each other. This is 12 millimeter. Whereas this is 4 millimeter. So this is what you will trace the scar. And ergonomically, you can go anterograde or retrograde, which also is very helpful, depending if you're sitting behind the patient or in front of the patient. So you have that dexterity of going anterograde or retrograde. So this is what the screen will look like. So you can see, for example, the fluence, the energy gives you the depth, and you can see how deep you are. So 10, this is on the 1940, so it's very superficial. You're not deep. This is the density coverage. That's the scanner width. So you can adjust the scanner width here, adjust the fluence, and adjust the density. So let's talk about the 1550. So this is obviously an Indian patient, you can see. It's not a problem. 1550 is fine. He has scars. Okay, of course you can treat with other modalities. He wanted the Frax. So what I like to do, I like to use the 4 or a 6 millimeter. Just 2-3 passes on the individual scars. Really get good coagulation and swelling and edema in the individual scars. So I know that there's coagulation in the scars. And then do a 12 millimeter, treat the entire area. Again, you can see some scarring here. That's what you could treat with a 1550. Another, higher skin type, Indian patients, okay? Can I treat with microneedling RF? Yes, you can. But you're going to have to pay for the consumables, and you need the anesthesia. I could also do it with the 1550. 4 to 6 millimeter, treat the individual scars, and then 10 millimeter, treat the entire area. And then you can also then add in your lateral thinking, maybe a little bit of subcision under one of the scars, maybe a little bit of a filler under each scar, that's fine. But the energy-based device is going to be with a non-ablative fractional 1550. I like the narrow scanner width for the individual scars, larger scanner width for the entire area. Stretch marks, again, 6 millimeter, for example. Trace the individual's stretch marks, and then you can use a 12 millimeter to blend in the entire area. Pores, dilated pores. You can see the dilated pores here. They're all nice and tight. Okay, so again, just 1550. You don't need to go very deep in this case. 400, 500 micron deep is enough. Few passes, and you get nice improvement. Again, surgical scars. Look here, for example. You don't need a 12 millimeter. This is perfect for a 4 millimeter. Just a 4 millimeter, 2, 3 passes. It will take you 40 seconds. 40 seconds. No consumable, okay? Here, so you treat the vascular. So in this case, she had the nodulus, the vascular handpiece, and then the 1550. Surgical scars. So here, again, these scars are otherwise very difficult. So you got to treat with a fractional CO2. She's going to have a lot of crusting and oozing, and she will do it once, she will not do it again. I know these patients. So 4 millimeter 1550, 3-4 passes, 4 millimeter, then 12 millimeter low density, the entire area. And then you get improvement in the scars. Same here, 4 millimeter, the other side. Same here, Frax 1550. Nice improvement in the scar. And also with the, of course you can combine. So I combined with the vascular handpiece, okay? Barcode lines, still, I think ablative is your gold standard. But you can still get some improvement with the 1550, but you need few more sessions, okay? Acne, so combination of low dose isotretinoin, okay? Low dose isotretinoin, vascular laser, and then now there is more evidence that if you start very early on with very light 1550, you actually prevent deep scars, and you can then treat at the macular stage. So when they have macular erythema of the scars, you can combine the vascular with the light fractional. This patient, you can see isolated atrophic scars. So if you're just going to treat the entire cheeks, she's going to get modest improvement. Because why would you blast this area and this area with a lot of energy? She really has isolated scars. So the best thing to do is to go on the 1550, 4 millimeter, okay? Put it on the expert mode, which means you can go back and forth. So back and forth, 3-4 passes, and you will see, volcanoes of swelling and of edema. Then go on a 10 or 12 millimeter, couple of passes on the cheek, and you get very nice results. See, so scanner, narrow scanner width on the individual scars, followed by a wider scanner width for the entire area. Only Frax, nothing else, okay? This patient didn't want the fractional CO2, obviously because of the crusting and the oozing, and then it's just not going to be possible. This is after about 3 sessions. Is the scar still there? Yes. Is it better? Of course. Is the patient happy? Very happy, and that's what matters, okay? You do the best you can. It's not about magic. Same here. Again, this is in the knee, slightly pigmented, so the combination of the 1550, 1940, flatter scar, pigmentless, patient is very happy. Otherwise, it's very difficult to treat. How will you treat this otherwise? Okay, same here, you can see. And then it improves the color, and the scar is a bit flatter. Okay, it's a little bumpy raised here and pigmented. So when you treat with the CO2 here, you're only going to worsen the pigmentation. That's the problem. Okay, so this is where You can, of course, combine with the Picoway. You can. So you can use Picoway for the pigment, but then for this, hypertrophic components, you can just go with the 1550. Again, combination of vascular and 1550. Look at this. Again, combination of vascular and 1550. This was a burn scar, an unfortunate patient. So he had lots of pulse dye laser. Of course, it works very well in the burn scars, but he also needed the non-ablative fractional. Okay, so you combine vascular with non-ablative fractional. This has become now the standard. The other thing that you can do, which is a really nice treatment, and it takes you again 2 minutes, we timed it, is just lip rejuvenation. So 1550, few passes, and you get nice plumping of the lips. Of course, some of the swelling after a few days will calm down, but you get also stimulation of collagen. You get better lips when you keep doing it. Patients report that the color improves, the plumpness of the lips improves. I can think of 3 scenarios where this would be very appropriate. Patients with hypersensitivity to some fillers. We have 2 patients in our clinic. Any type of filler they have reactions. This would be a great way of saying, well, we can just plump up your lips. You don't need to have the hypersensitivity risk with fillers. So that's one. Another one is a patient who is needle phobic. And there are patients who are just scared of needles, even if you numb them. This is another option. And the third case is those women who want maybe some fillers, but are very scared. Maybe they don't like the swelling. They don't want to dissolve them. You can just say, well, we can do it. You can see how they will look, and then it will go down. If you don't like it, you can then forget about it. So it's very easy. You can do a 6 or an 8 millimeter spot, 3-4 passes. You get nice plumping. So just warn them. Sometimes there might be a little bit of dryness, so they may need to use the lip balm, but everyone is very happy with the results. This is me in one of the workshops. We did that. Now, ideally, I want to fold some gauze between the lip and the teeth, but again, you just get on with what you have. So that's on an 8 millimeter thing, 25%, 25 millijoule. You don't need to go much higher, just do a few passes, and then you can see afterwards, immediately afterwards. Very nice, and plumper lips. And the advantage of this over the fillers is you don't have the lumpiness, you don't have the bruise, you don't have the unevenness. You know how with fillers, lips, anyone who's done lips for women, oh, I think it's higher here. Do you not agree? I think this is lower, this is going down, this is going up. None of that with the Frax. You do it, everything swells, everyone is happy. You don't have these conversations with the patients. Another case before and after, and it's nice. Right, so that was 1550. Now let's talk about the 1940. This is Sharon, typical English woman. She came in, she said, I want to look good. Now, I want to look good doesn't mean always collagen. Because if I say to her, well, I'll give you 30% collagen improvement, she'll say, well, what? What is collagen? So this is just 1940. Of course, you can use nano or pico for the pigments. That's not the idea, but the skin is glowing. So the pigment is gone, but there's something about the tactile element, she says, that the skin just glows. And that is because the 1940 renews the epidermis. So the epidermis is just going to feel smoother as the stratum corneum flattens, so the light reflection is nicer. And that's why, look, the skin is just nicer and smoother, and the pigment is clearing, and that's just with the 1940. And again, this is just from a close-up. It's sometimes difficult to see, but the quality of the skin improves, and the pigment improves too. So, for example, here you can do the combination of a little bit of IPL in 1940, very difficult areas to treat. Again here, this peppering, so you can just do a little bit of light IPL or a very little toning. So if she wants to say, I want to improve this, what I would do, I'll do a little bit of toning. Some of the lenticels, I'll go for very light frosting, and then Frax 1940. So you can combine. If you have all the machines, what you can do is you can pick away the standout lentigos. Remember, lentigos need to be chased. So you hit the lentigos with the zoom, then you do Frax 1940 for the whole face. Okay? Or you can do HIFU when you want tightening, and then give them 1940 for the glow. So they come here, then by the time they will get the lifting, they're already in love with the glow of the face. So again, and you can do that in the same session because this is very superficial. You can start combining with skin boosters. Nowadays, everyone wants skin boosters. That's all they talk about. The growth is in skin boosters. Brilliant. So if someone says, my son is getting married in 1 month, what shall I do? Frax 1940 and skin boosters. Skin is going to glow, be nice and hydrated, very good for the photographs. Okay? But we also know that the Frax 1940 gives us that cracks, the break in the epidermal barrier, so we can enhance that for cosmeceutical delivery, which means anything we put on the skin is going to be absorbed better. So we can use the 1940 as transdermal cosmeceutical delivery. We know that from data from the 1927, which showed, of course, that you get this epidermal injury, we can then, anything we put on the skin is going to be more absorbed. So what can we put on the skin? Well, depends on what the pathology is. You can put tranexamic acid if it's melasma. You can put vitamin C, photo damage. You can put hyaluronic acid, non-cross-linked, if you want more of a glow, okay? The world is your oyster. You can put any of the serums. Trust me, this is business. This is just business. Science aside, business. If you tell any female patients, madam, what I'm going to do is I'm going to do a little bit of rejuvenation, and then I'm going to put some nice serum on afterwards that is going to just give nutrition to the skin, biorevitalization, healthier of the skin. How many women do you think will say, oh no? They all love it, okay? So it's just, you have to talk the language of the patient. That's what they want, this is what they can get, okay? Can you inject it? You can inject it, but you also have the advantage of the coagulation that you get here, that rejuvenation effect that you get from the energy-based device, which you cannot get from the injection, and then the advantage of delivery of the molecules through topical application. So this is again something I published on laser-assisted drug delivery, because many years ago I was part of a split-phase study where we actually used this product post-fractional. So we did a split-phase study. Half of the face, so the whole face was treated with fractional. Half of the face had this, the other half face didn't. And we definitely saw that there was increase in beta fibroblast growth factor and reduction in downtime. So we know that when we combine fractional with cosmeceuticals, we have an additional advantage. Then came this study that showed we get these microchannels, of course, which is enhancement of delivery. And look what happens when it's combined with the laser. In other words, if you put a serum on the skin, some of it is going to be absorbed, most of it is going to stay on the skin, we know that. But if you pre-treat with the non-ablative fractional laser, the 1940 or 1927, then you have 17 times higher absorption of the cosmeceutical. So this is why now we use a lot of this wavelength for cosmeceutical delivery, okay? And it's become very patient like this, she can benefit from vitamin C. So she can get the 1940 plus a vitamin C serum, okay? Patient like this, what do you think she would benefit from? Tranexamic acid. So this is a combination treatment. She has also redness. So low fluence vascular, because melasma has a vascular component. Then Frax 1940, and then tranexamic acid. Tranexamic acid is going to help with both her redness as well as melasma. And then very nice, smooth, clear skin, okay? And you make a protocol for the patient. You sit down with the patient, madam, I'm going to do first 2 sessions, low-level vascular. Can you see you have a lot of vascularity? Yes, I can see. Then I'm going to do 2-3 sessions of low-energy Frax 1940, plus the tranexamic acid. If she trusts you and sits with you, you're going to give her results. Same here. Indian patient, tranexamic acid, skin is very healthy and glow. Same here. Now, this is also interesting. This is a hypopigmented atrophic scar. So, how to approach this? Excimer laser, 308 nanometer excimer laser, Frax 1940, and twice daily application of bimatoprost, prostaglandin drops. Because remember, the bimatoprost prostaglandin repigments the skin. So you get repigmentation. Very happy with the results. So once again, for hypopigmented atrophic scars, excimer, Frax 1940, bimatoprost drops twice daily. Vitamin C, again, you can do it for the back of the hands. So Not necessarily with the Frax, with the Pico, you can also do it with the Frax. You can see here, with the Frax. So what you can do is you can use a 4mm, treat the individual ones, and then use a wider scanner with treat the entire area. And then think lateral. Maybe some fillers in the hand. Maybe some skin boosters in the hand. Okay? So the patient is coming to you with one thing, but then maybe there's something else you can help them with. And that's how you build up the practice. Skin type 6. So how would you treat this patient? Will you inject with steroid, or he's going to get hypopigmentation? I know these. This is skin type 6. We have many of them. So you treat with the NDAG, of course, because skin type 6. And then Frax 1940 and delivery of tranexamic acid. Here, after the NDAG, just a little bit of hyaluronidase and mild steroid. And then Frax 1940 and delivery of tranexamic acid for the pigmentation. Flat seborrheic keratosis, you can also treat with the 1940. And it's also cleared for actinic keratosis. Not necessarily a problem in Qatar, but remember, you have actinic keratosis is just dysplasia in the epidermis. So if you clear that epidermis, it's going to clear too. Mild rhinophyma, low dose isotretinoin twice a week, 20 milligram twice a week, vascular laser and Frax. So you don't need the CO2 resurfacing and the erbium and all of that. Just low dose isotretinoin, a little bit of vascular laser for the vascularity, and for the bumps on the surface, just the Frax. So why was Sharon happy? I'll tell you why she was happy. Because this is the ideal skin for beauty. Skin that is smooth, porcelain-like, it glows, nice light reflection, no redness, no pigment, makeup sits nicely, and all of these you can get with a 1940. Because there are two types of light reflection. When we have a smooth surface, we get a specular homogeneous light reflection. This is why when we inject Botox in the forehead shines smooth. The light reflection is even. When we have dull skin, the light reflection is diffuse, so it doesn't look nice. So if you look at these two rocks, the collagen is the same. There's no change in the collagen. But this looks nicer because of the light reflection. So it's an optical illusion. This is why the women who have the 1940 are much happier because of the nice light reflection. So we perceive them as attractive. And this is science and it's been published. Facial radiance influences facial attractiveness. It's been known that when we look at someone, within a second, we decide if that person is attractive or not, largely based on the facial radiance. So you can be a brilliant injector and do all the vectors and do this, but if the quality of the skin is not good, you're not going to score high. So nowadays, it's all about good quality skin. Skincare can only do so much. With the 1940, it can help you more. And actually in Japan, they did a study where they put volunteers in an MRI scan. And they looked at the activity of the brain that is usually active when we see someone pretty. And the same face was dull or nice, smooth facial radius. And all of the volunteers had more brain activity with radiant skin. So even for the same proportion of the face, when the skin is nicely glowing and radiant, we perceive them as more attractive. Right. What do you think has happened in this lady? This patient came for this. She said, I wanted HIFU. I said, well, but the quality of the skin. She said, oh, well, I'm bothered about this. So I offered her, free of charge, the 1940 in the same session because I knew she would be a great model. So I did the HIFU, and then in the same session, very quickly, 1940, look at the results. There is tightening. She says, this I'm happy with, but I really love how good the skin is. So that is an opportunity for you. So someone might, again, come for something, you can see something else. So 1940 I use on pretty much everyone. You know when sometimes we get patients who want the treatment, but you can't really justify it. They say, Abi laser. You don't see any, there's no melasma, there's no redness, they just want a laser. The 1940 will be the best laser to use. They're going to get nice smooth skin, nice glow, low risk of any complications. That is my go-to. And again, I like to combine it a lot with HIFU. You can see close-up view, much smoother skin, better quality skin. Right, so now we will have some live treatments. Any questions? I need a glass of water first before the questions. Any questions? 1550 or 1940, yes. We have a microphone. Okay. Okay, now, so as you know, as a dermatologist, the actinic keratosis comes in different grading. So we have the very light, thin one and the very hypertrophic, almost boinoid-like ones. So of course, for the very hypertrophic ones, we do curettage or destructive therapy. But for the thin actinic keratosis, the 1940 is actually cleared for that. So you can use, and you can see on the Frax Pro, if you go on the screen, you can check it now. There is a modality for actinic keratosis, because what it does, it resurfaces the entire epidermis. So remember, for the thin actinic keratosis, it's just in the basal layer of the epidermis. So, you know, when you have a scalp full of actinic dysplasia and we call it now field dysplasia, and very thin actinic keratosis, 1940 for the entire scalp is brilliant for that. So it's for the grade 1 and 2 actinic keratosis, the thin ones. You can use the Frax 1940. Yeah? Sorry? The 1940, because it's superficial. Superficial, yes. Can we get the mic here, please? Oh, you have the mic. Oh, sorry.
You mentioned that you are combining the pulsed lasers with 1550 in case of post-acne scars.
Yes.
Weakness and to
Yes.
treat the vascular defect and the
Correct.
So are you combining the two modalities at the same session?
Okay, so the question, just so everyone can hear, the question was, in those patients with post-acne erythema and acne scars, when we combine the vascular laser with the 1550, and you get the dual advantage. The pulse dye laser, the vascular laser is treating the vascularity, and the 1550 is remodeling and preventing the scar. It depends on the patient, and it depends on how much erythema there is. If it's a lot of post-acne erythema, the first two treatments would just do the vascular, okay? And then move to the combination of the vascular and 1550. If it's mild erythema and the patient is traveling from a long distance and says, you know, it's always costly for me to come, then I will customize it, and you can still do both in the same session. If you are doing both, do not go for purpuric mode with the vascular. So, you know, with the post-acne erythema alone, some doctors in the lighter skin types like to go for a very mild purpura. You don't actually have to have mild purpura. There was a nice study from Murad Alam in Chicago. He did split face study, purpura, no purpura, same results. I don't like to use purpura. Some doctors are trained to get purpura in every post-acne erythema. If you do get purpura, don't do the 50. But if you want to combine both, do it in non-purpuric, and of course, vascular first, followed by 1550. So in 50% of the cases, I combine. In other 50% of the cases, I start maybe first with the vascular, then move over to the combination. It also depends. Sometimes patients, oh, I'm really nervous if I use 2 lasers. Don't be nervous. We use the pulse dye laser first, clear a lot of the erythema. They build trust. They're less nervous. Then I do the combination.
What about the hypertrophic scars?
Yes.
And the role of treating patients with the 1550 or the hypertrophic scars?
Yeah, okay. So for the very hypertrophic, you still need the injections or fractional CO2 for the very hypertrophic. But I will say up to 3, maybe even up to 4 millimeter max hypertrophic, you can still combine with a vascular laser, the 1550 in high energy, and combine that with the injection. So you can still use the 1550. Remember, on some of the images you saw on these surgical scars, they are hypertrophic. I just use the 1550. But if you really have very thick hypertrophic scars, you will get better results with the fractional CO2. So up to 4 millimeter, 3 millimeter, I would say you can still try the 1550. You're welcome.
I used before to have the 1550 and non-ablative laser.
Yes.
Scar repair and what scar. And also I had earlier.
Yes.
Earlier fractional laser, which is ablative. From your point of view, which is better for the ablative or non-ablative?
No, you know, it depends on, first of all, if the patient wants downtime or no downtime. And it depends on the context of what we are treating. I really think for the 1550, I think I get better results than with the erbium. Because I know I can go deep, okay? And I can do more passes, and it's still safer. So with the fractional erbium, if you are going to, for example, be very intense, then the risk of PIH goes higher. I actually no longer use fractional erbium, okay? I no longer use fractional erbium. But in the case I either use CO2 or I use 1550. I will use CO2 when it's a thick scar, okay? Or very deep wrinkles, or I will use the 1550. I think if you're familiar with the erbium and you get the results that you think is a niche, is fine. But I think really the safety margin with the 1550 is higher. Because you can do more passes and you're still safe. So maybe if it's mild treatments, you may not see much of a difference. But when you're doing an intensive treatment, you will see that with the 1550, you get better results, but still low risk. Yes. Yes. Okay. So there are a number of differences. First of all, the actual sweet spots of the water absorption is 1935. So the 1940 is a bit closer to the 1935 compared to the 1927. That's one. The second key advantage really is that the adjustment of the spot size. So with the 1940, with this 1940, you can adjust the spot size. So you can get a 4 millimeter to treat individual areas, lentigos or flat seborrheic keratosis or actinic keratosis. Then you can treat with a 10 or a 12 millimeter a larger area. With many of the existing 1927, it's like different handpieces, and you don't have the full range of all the spot sizes. So that is, to me, the biggest advantage. And the other advantage is also you have the cooling inside the machine. So you have cooling inside the machine, so you're also having some comfort and cooling for the treatments when you're treating. Okay? Yeah? Mohammed, sorry. Microphone, for there's a question there. There.
Hello, thank you very
Welcome.
much for this presentation.
Welcome.
I want to ask about lip plumping.
Yes.
Do you think it's a good idea to advise patients to do like this procedure and pay for this? And since it will disappear after a few days, I think, or how long did you think it will last?
Well, we have a model, we were going to do it. So it's not about doing it only as a single procedure, okay? First of all, you don't have to charge high. So, I mean, I'm not going to the discussion lips or no lips, because why are people injecting fillers in the lips? So that's a different discussion. But if you look at how much do you pay per syringe of filler, there is no one who will do a lip filler less than $150 because they're not going to get any money because you have consumable. Now, the advantage here is you have zero consumable. So in many cases, in many of my patients, I just do the lips for free afterwards if they want. So you can charge very little because there's no consumable, zero. It's costing you nothing. So you can lower the price. You can introduce that as a treatment, or it can be as an add-on treatment. They're doing other things, and you can plump up the lips. But when you do repeated treatments, it lasts very long. Well, I mean, well, you get the color improvements. The color improvements is long term. The color improvements. Yes. So if you have someone who's 50 with a lot of actinic dysplasia, and you know they have these very whitish, pale lips, and if you do few of them they start to become plumper and also more pink. Now that pinkness is long term, because remember, you get neovascularization. Because it's not ablative fracture, you get neovascularization. So if it's purely a 25-year-old girl for just plumping, yeah, that's short effect, but they need multiple treatments. But if it's a more mature person for plumping and color, that is long term. But I treat for my regular patients, I charge for free or charge very little because there's no consumable. So you're not going to charge the same as you charge with a lip filler. It's different. Yeah?
Thank you, Doctor.
Welcome.
So, which is the downtime for atrophic acne scar treatment, approximately?
Well, with my method, which is a little bit more aggressive, where I use the 4 millimeter on individual scars, doing a few passes until it's edema, 5 to 6 days. Yeah. Redness and some swelling. But it peaks at day 3. So up to 3 days, they're swollen. Then it's less. By day 7, day 8, they're absolutely fine.
And home care advice?
Well, moisturizers. So, whatever they like. So whether it's a Cicaplast gel or, many of the post-Soviet countries like to use Bipanthol or Panthenol. So whatever they like, and sun protection. So keep it simple. Hydration and sun protection.
And for how long the patients with a 1940 gene with the
So that depends on the density and the number of passes that you're doing. If you go for 30% density, because the minimum is 20%. If you go to 30% density and do 4 passes, day 5, day 6, they're still peeling a little bit. If you do 20% density and 2 passes, day 2, day 3 maximum. So it really depends also on the density and the number of passes. The higher the density and the more passes, you shift to maybe 5, 6 days. The lowest will be 2 to 3 days.
So they can still go to the office?
Yes, absolutely. Yeah, they can still go to the office and yes, absolutely. They don't actually peel, but what happens is where they have the lentigos, they will see tiny little dark dots, and the dark dots slowly lighten, but it's not actually true peeling like a chemical peel. Yeah. It's a very popular treatment for those low downtime, yeah, of course. If they want 0 downtime, I use the Picoway Resolve. So, Picoway Resolve, Frax 1940, maybe microneedling RF, and then ablative. So it's, in terms of downtime. And yes.
Thank you.
Welcome. Thank you for staying. Thank you for staying so late.
I have a short question regarding the combination of headpiece of Frax Pro and laser instead of the second headpiece.
Yes.
Should we get the same results or we refer to the percentage?
Okay, so I don't, but colleagues of mine in Australia who have both have tested, and they get exactly the same results with the 1940 than the laser MD. There is no difference in terms of the outcome. So the outcome is the same if we are treating with standard parameters. But the difference, as I mentioned, is the fact that when you are customizing certain areas, you have the advantage of the scanner width with the 1940 that you can add on. But you can do, if you have laser MD and you just have the 1550, you can do the combination and you'll get the same results as the 1550 and 1940. Yeah. Any other? Do you have a question? No? How's your face? Nice erythema and the lenticels are darkening. Right, so once again to summarize, 1550 deep, 1940 superficial, 1940 more of a cosmetic wavelength, more of the aesthetic patient, glow, all of that. 1550 a little bit more of the medical patient, scars, and the combination of the two is for someone in between, really. Okay, so now we have treatment. Okay, perfect. So now you can see it's the 1940, and you have 2 choices. You have two choices. Just zoom in a bit. Perfect. Yes, you can see.
Focus.
Actinic keratosis and skin resurfacing. So there's also a choice for actinic keratosis. You can see there to the right. Actinic keratosis. Can we get the pointer here as well? The pointer. Actinic keratosis and skin resurfacing.
And I was thinking about the actinic cheilitis. Would you
Yes, I have patients with actinic cheilitis.
So, and you use the same?
1940. I use 1940 and then I ask them to use Epidix twice a week.
Okay,
Yeah.
for how long?
Until it disappears. I usually give 2 treatments, 6 weeks apart, and in between they use twice a week Epidix, and then I see them, and if most of it is gone, it's fine. If it's a small area residual, they can just continue the Epidix until that clears.
Okay, we don't have a Epidix with you. Yeah, sure. We have the emic mode, so...
Yeah, you can also use the same, yeah. My colleague was asking about actinic cheilitis, which I also have some patients, Australians, New Zealanders, they all have actinic cheilitis. I like the 1940 and then twice a week Epidix cream. If you don't have Epidix, you can also use Imicumod. So 1940 for actinic cheilitis is also very nice. And this is what I meant about the lip. So it depends. If you want neovascularization, it's 1550. It's more actinic cheilitis, 1940. Yeah. Phosphoridized spots, nothing works. Nothing works. Nothing works. I've tried everything. Patients come and say there's a report about cryotherapy, there's a report about this. In my hands, nothing has worked. Okay, yeah. So skin resurfacing. So you can see here you can choose. You could choose skin type, or we can choose other skin type 3. And then no tan, low tan, and then face. And then it already gives us the parameters, which are actually very decent parameters. 170 micron deep, 10 millijoule, 30% density, 10 millimeter. With this, she's going to have about 4 days of downtime. If she says 4 days is too much for me, I'm going to decrease that to 20%, and I'm only going to do 2 passes. Okay? So I'm going to do 3 passes on this. Yeah.
Just for information, when you're diagnosing what you're going to improve, the camera was off. So maybe you would like to say what you're...
So let's zoom into the patient. Yeah. Zoom into the patient, and then just slightly turn your head that way, please. Thank you. Okay, have a look at the patient. Okay, so really what you see is just some superficial lentigos, okay? Watch carefully if there is melasma, because if there is melasma, I always go with the low density, low energy. So, you know, always, melasma is one of the conditions that I have huge respect for, okay? So a little bit of lentigos, skin surface can be improved, but there isn't really much else. So she will be a great candidate for the 1940. This would be a great candidate for the 1940. So we can bring this a bit closer. This, by the way, doesn't need goggles, so we are a little bit more relaxed. Okay, so 1940, improve the superficial lentigos, the glow, the surface of the skin. Here we go. It is embarrassingly easy to do. I mean, the treatment you will learn in 20 seconds. The rest is just patient selection and parameters. So obviously when you're treating, you talk to the patients, maybe they listen to some nice music, whatever, because otherwise it's just, you know, very simple, easy treatment. So in many countries where treatments are delegated to the nurses and the practitioners, like in the United States, for example, this treatment is delegated to the nurses and the practitioners. The doctor makes the diagnosis, suggests the parameters, and then your staff can continue the treatment. That is obviously depending on the country and their legislation. 3. Yeah, 3 is the average. As I said, if you have someone, let's say you have an Australian patient with a lot of sun damage and really doesn't mind the downtime, I sometimes go up to 5 passes. If you have someone who's extremely nervous and really doesn't want much downtime, 2 passes. On average, 3 to 4. Sorry? Oh, okay, sure. I'm almost at the end of my second pass. Again, it's a very fast treatment. We have a low topical anesthetic cream here. This is actually the least painful. The least. So some patients without local anesthetic, I like to put anesthetic cream, but 15, 20 minutes is enough. The 15-50 is a bit more painful. Sorry? We can ask the patient, is it painful? No, she's saying no. Yes. Sorry? Yeah, you have to touch because the roller... No, this, you just detach, antiseptic, and attach it again. There are 0 consumables. 0 consumables. And this is another advantage from the Frax Dual, for example. The Frax Dual has only large handpiece and small handpiece, and that is a consumable. When it's a consumable, trust me, I have a lot of experience. When it's a consumable, it blurs your judgment. You're starting to make judgment based on the consumables. But when you don't have consumables, you can be a bit more generous with the treatments. I bought the machine 3-4 years ago when it first started. Never changed. By the way, it comes with a box of 20. So you have 20. Yeah, because they want the consumables. They want the money. Okay, are you asking how much I charge or how much clinics charge? Okay, no, I'll tell you what. So the minimum some clinics charge is $300 or the equivalent of $300. And the crazy ones, because they are, in Knightsbridge or in Harrods, charge $1,200. Yeah, for the Gulf Arabs who pay. So I charge about $500 a session. So in the United States, very few doctors actually do this treatment because it's embarrassingly easy. It's so easy that, they train the nurse does it. So the doctor makes a diagnosis, makes a suggested treatment parameters, delegates to the nurse. And they treat, again, they charge $400 or $500. Those New York-based doctors in California, $500, $600. The ones in the Midwest, maybe $300, $400. But no one charges less than $300. No one charges. Yeah, you get the money back in 1 month, 2 months, depending on how many patients you have, because there are no consumables, and that's the biggest advantage. Right. So you can see the endpoint, pinkness, bit of redness. We will continue treating. We'll go to the next side. Any other?
Did you explain the noise?
So, yeah, what you hear, that's a little bit of soft cool. That's the cooling that, again, is more gentle on the skin. And that's another comparison with the 1927. So first of all, the machine gives you the suggested parameters. The rest is experience, but I can tell you, if you are 25% density, you're going to get results, okay? And then remember, the density also depends on the passes. I'll explain how. Imagine you have 20% density, but you do four passes. It's got to be almost the equivalent of 3 passes on 25% density. So 25% density is a reasonable density, and minimum 3 passes is reasonable. That is going to be your standard. And then you deviate from that based on, impact, downtime. But if you do on everyone, 10 millijoule, 25%, 3 passes on everyone, everyone gets results. Yeah? That's why I say it is a very easy device to handle. Yeah? Yeah, sure. Ask. No. So now there is nothing fired. This only fires scans when it's in motion. When the roller is in motion, rolling on the skin, it fires. Like this, it's not firing. Okay? And look watch what happens. Can you hear the tit? It's saying it's too fast, it's not scanning. So you don't want to hear that. You just take your time and you scan. And again, if you have 20%, okay, it's going to be a little faster. If you have 40%, you have to be much slower because the scanner needs more time to scan 40%. So some people go, zzz, no, you have to adjust the speed based on your density, okay?
We have the other machine. We have the 1550 and 19227. So it's really painful for my patients because I have...
The 1550 is painful or the 1927? Which one is painful, sorry? No, the 1940 here is not painful because you have cooling. I think in the Yes, but the cooling is very important. That's why the cooling is calm. Yeah, here there's cooling. There's cooling. And the cooling is inside the machine. There's not an external. Yes, and that is the biggest disadvantage. You add the cooling, you buy the consumables, so yes, but here less. No. We did 3 passes each side. Okay? Right, so I'll show you. Sorry, my colleague. Yeah, I'll show you. Now we finished the treatment. Look, I'm just going to detach this, antiseptic, and then attach it again. This is not a consumable. Yeah, it's a consumable, of course.
For 3 to 4 patients, we need to change it.
I know. But I know see, this is the thing. You know, companies start to compete, so they know consumables is a big cost. So when you have non-consumables, it's easier.
The tape should be used after special juice. This Frax, you have to use.
I know. I had Fraxel Dual for many years. I know.
You know how to get money from it.
No, look, I have seen many clinics and many doctors. When a device has no consumables, it performs better. Because the judgment of the doctor is always based, if it's a consumable, you're never going to give something for free, you're never going to do something extra because you think, oh, it's going to cost more. When it's no consumable, do extra. Give for free, come back again. So the patients get better results. This is my impression everywhere. You agree, yeah. It's human nature. You have to pay for it. When it's free.
And then you make your patients
more
Definitely.
some service research.
And usually, who sees patients is real life. You finish with this. Can I show you I have this? Can I show you I have that? Does it work on this? I actually have a stretch mark here. Do you think it will work? If it's consumable, you're not going to make any money. But if it's non-consumable, it's fine. Okay, well, we'll put some anesthetic cream, come back and do it. Depends on how special that patient is. All of these are real life scenarios. Finished here. Yeah. So aftercare, you can put Cicaplast, Cicalfate, Panthenol, aloe vera gel.
Vitamin C.
Yeah, vitamin C, tranexamic acid, whatever you want. I use the SkinCeuticals Phytocorrector Gel. It's a nice one. You can also use Aquaphor from Eucerin. It's fine too.
I can use it after plasma or physiotherapy or skin booster. It's okay.
Brilliant for that. No, you can do PRP post this. Now people are doing exosomes because that's now the new trendy stuff. So you can do exosomes, you can do PRP, you can do skin boosters, you can do vitamins, biorevitalization, everything. I really like NCTF. I have no involvement in the company, but Filmed does NCTF. Really nice brightening and a glow also. I use that post 1940. You can do anything you want. Yeah, the combination. Thank you. So this patient will have about 3 days, maximum 4 days of a little bit of redness and darkening of the lentigos. Zoom in, cover the eyes, please. You can see we have acne scars. This is a perfect case for the 1550. Really, this is a perfect case for 1550. Acne scars in a skin of color, shall we say. You're not going to do CO2 because you're risking hyperpigmentation. You can do microneedling RF. You can. Okay, it's just another way of approaching things. But you can also very nicely do the 1550, and you have added advantages, as I said. With the microneedling RF, you're committed to the spot size. Here you can adjust the spot size, and also no consumables. So the microneedling RF, you still have to pay for the needles. Okay, and they're getting more and more expensive. So for acne scars, I don't really use microneedling RF. I don't see the points. I can do the 1550. So, right, if you see here, she does, pretty much the entire cheek has scars. Nevertheless, there are some scars that are a little bit more deeper. So what I'm going to do, I'm going to, on the 4 millimeter, okay, and I'm going to do a few passes on the 4 millimeter. So I go on the expert mode, and then I go on both sides. So this means I can go back and forth, back and forth, back and forth very fast. So I'm painting each scar. Is that large, by the way?
Sorry?
Is that large gloves? Oh, if it's large, I will wear. So what I'm doing here, I'm using 4 millimeter. So it's a narrow scanner width. Because it's 4 millimeter, the dots are going to be closer to each other. That's why I use 20% density. And then I go back and forth on individual scars. Because I want to make sure that the individual scars get good coagulation. Toward me. Thank you. Okay, can we focus on the right cheek, please? Can you see on the right cheek, what you can see is islands of erythema and edema. Can you see that? You can see isolated areas of erythema and edema. These are the individual atrophic scars. I have gone back and forth with a 4 millimeter. So I know for sure there's good coagulation there. Okay? And again, this is an advantage over the microneedling RF. There is you chook. Here, boom. On the individual scars, I can see good erythema and edema. I know for sure the individual scars have been treated. Now I'm going on the 12 millimeter, and then I'm going to increase the density, and then I'm going to treat the entire cheek. So the advantage of this method is I know for sure the individual scars have been coagulated. And then they get double hit with the multiple passes. You can see the individual scars are edema. If you think about it, this is basically targeted treatments versus field treatments. Targeted treatment for the individual scars, field treatment for the entire ear area. Three passes. 3 passes here. Now we're going to go to the other side. Have you noticed the patients are not really reporting any pain? It's actually not that painful. Done. Okay, we can, Mona can put the aftercare. Okay. We can take this, antiseptic. Right, I want to show you something special, something you will like. that no other non-ablative fractional can do. Can we zoom in, please? This is advanced. On the screen, please. We're done with the patient. Just 1 second. Maybe you can take the patient and do the aftercare.
Yeah.
Yeah, I want it to zoom in a little bit more. Yeah, perfect. Perfect. Right. Let me show you why this device is better than the other ones, okay? Yeah. Watch here. This is the only device, non-ablative fractional, that allows you to change the pulse duration. Pulse duration. Remember, we have few variables. The wavelength dictates the interaction, which is water. So we have 1550, and that interacts with water. Then the fluence gives you the depth of penetration. So how deep you're going to go is with a higher fluence. But the width of the individual column of coagulation depends on the pulse duration. Short pulse duration, narrow width. Long pulse duration, wider width. So watch here, when you go on the so-called expert mode, you have pulse time here, 2.7 milliseconds. And watch here, estimated width of the individual column, which is 350 micron. So what you can do, you can decrease the pulse duration, and that decreases the diameter of the individual coagulation. Skin type 6, this is what you will do to reduce the risk of PIH. On the other hand, if you have a very atrophic scar, you can go for a long pulse duration. .400 micron wide coagulation zone with a high density, and you have very good contraction of the tissue. No other non-ablative fractional can do that. This is the only non-ablative. Yes, this is the width of the individual column of coagulation. So you have narrow column with a short pulse, wide column with a longer pulse. And you can change that. You cannot with the Fraxal Dual. And you cannot with the Laser MD. You cannot change the pulse. So here, no. So you have depth. So you can dictate depth, width of each coagulation zone, which represents coagulation, and then you can change the density. But the impact is always going to be the width of the coagulation. So this is another trick that you can do for some of the small areas where there's a lot of atrophy. You can just increase the pulse duration. And then in some areas where it's dark skin, you just shorten the pulse duration. Okay? What do we have here? Lips. Have you had and increase that? I go on 8 millimeter. Did you take a before photo of the lips? No. It's always important to take a before photo, but now it's more swollen. Take a before photo. Yeah, taking photo.
How long stays the results of regeneration?
For lips?
I mean, the initial swelling will stay a few days, and then of course you will have a little bit of a rejuvenation effect. You need few treatments. Just like with rejuvenation on the face. It's never one single treatment. Do you want to cover the eyes, please? Remember, because it's zero consumable, you can do it on everyone. Yeah. Anything you charge is a plus. Whereas when you have a consumable, you'll have to start thinking margins. Right, so we will start. And again, Very simple. I like to do halves first, so I start with 1/2. That's 1. That's 2. 3. I'll do 4 passes. Okay. Now we're going to do the other half. So that's 4 passes. 2 minutes, 1 minute. Now we're going to do the same in the lower. So give me a gauze.
تشتغل من هنا لهنا؟
من هنا لهنا.
طب انا بس كان بلوكينج هاك الفاصل اللي جايه اخدها من بره لجوه.
Okay. This also reduces the pain to the teeth when you fold the gauze between the lip and the buccal mucosa. So you want me to go from, okay. Can you see? Can you see like this? Yeah, okay. This is 1 pass. It's much easier when you fold the gauze between the lip and the buccal mucosa. The lip comes out. Three. Done. That's it. You can take the gauze and put a lip balm. 4 passes. We will put something. Yeah, 4 passes. I can already see some plumping, but in a few minutes it's going to look very nice.